Assalamu alaikum wa rahmatullah. Welcome everyone to our Advanced Clinical Research Technique, Tools and Application webinar. My name is Ghanima Mtari and I'm going to be your first lecturer for today. So the first topic that we will be discussing today is quantitative study design. And from the name, quantitative means studying or conducting research that relies more importantly on the quantity or the numbers of participants rather than obtaining a quality information. Not to say that this information gathered through quantitative research isn't important, but rather it has its own applications and techniques. So first of all, we need to understand the topic of evidence-based medicine. So evidence-based healthcare is the consistent, explicit, and just the use of the current best evidence in making decisions about the care of individual patients. So it means the integration of individual clinical expertise with the best available external evidence from systematic research. And there are, of course, a hierarchy of evidence when we conduct certain studies, as the case report study is considered to be the weakest source of evidence in research, while systematic review of randomized controlled clinical trials is considered to be the most effective and strong evidence in terms of research findings. So systematic reviews are the scientific investigation in themselves, and they can synthesize the result of multiple primary investigations by using strategies that will limit bias and random errors. And these strategies include a comprehensive search of all potentially relevant articles and the use of some explicit reproducible criteria in the selection of articles for a review. So a primary research design and study characteristics are appraised and data are synthesized, and eventually the results are interpreted based on the information we have gathered. So how is this different from a normal literature review? The literature reviews are usually one individual opinion of the current state of knowledge, while this is inevitably limited and from a partial perspective only. So what can systematic review offer? It offers combining results that can increase the power and the precision of estimates of effectiveness, as well as when there are few or no studies that are found. This can help to pinpoint the crucial areas and questions that need further research to be investigating in this matter. So the process of literature or systematic review includes starting with a question, afterward checking the need, stating the objective, and outlining the eligibility criteria and the protocol. Also search for studies, assessing for inclusion, and compiling data sets with analyzing the result. Afterward, using analyzing methods such as meta-analysis or sensitivity, and afterward, we will structure a report for the review we have conducted. So, is this considered a good systematic review? We need to ask ourselves certain questions, including, did the review ask a clearly focused question? How well have they searched for all the studies which might be relevant? Also, how well have these studies been filtered? And how have the results been combined? And what were the results or the main findings? So an effective review include, for example, studying the source evidence that has been interpreted in various different ways, and afterward implementing a full review of the data by looking at what this performing of meta-analysis is conducted. Also assessing heterogeneity methods when we are conducting systematic review, and these can include tests of statistical significance such as chi-square test, and the most used measure is called the chi-square test. This is also an example of the SALT review study. So after conducting a study, it can be given a grade of assessment. That is the summary of, do we believe that the results from these studies are reliable, assessing the risk of bias, also assessing inconsistency, publication bias, imprecision, and indirectness in general. So using sources such as the Cochrane Collaboration Library is a great source of information, as international non-profit organizations that prepare, maintain, and even disseminate systematic up-to-date reviews of healthcare interventions. So mainly, but not exclusively, they review randomized controlled trial and they support systematic reviews in these processes. So the best source of systematic reviews is the Cochrane Library, and it is considered a big database of abstract review for effectiveness. So they play a role in training and supporting systematic reviewers, increasing the number of systematic reviews and coverage of clinical areas, developing methodology, and producing systematic reviews that are updated consistently. So overall, a good systematic review can inform our own clinical practice individually and via guidelines, also inform the research agenda, and are considered the best place to look for evidence. In addition to it can be useful and well-cited publication. So for quantitative study design, it is based on the scientific methods of using deductive reasoning. And researcher forms a hypothesis, they collect data in an investigation of the problem, and then uses that data from the investigation after analysis is made and conclusions are shared. So this will prove the hypotheses that are either true or false in general. So there are 4 types of quantitative study design, including the experimental studies, the comparative studies, the correlation, and the survey studies in general. So these experimental studies are often called true experimentation. They use the scientific method to establish cause-effect relationship among variables in a research study. Also, the researchers make an effort to control for all variables except the ones that are being manipulated. In addition to the effects of the independent variables on the dependent variables that are collected and analyzed for a relationship. So the major features that distinguishes the experimental research from other type of research is that the researcher can manipulate the independent variables depending on their hypothesis. Also, the subjects are randomly assigned to the experimental treatments, and the experimental design should be developed to ensure internal and external validity of the study. So the internal validity are the results of the study that are caused by factors included in the study or are caused by other factors, the external variables, which are not part of the study. So the external variables are unwanted variables that may have an effect on the experiment outcome. For example, if you are worried about gender, only including one gender in the study will have an external variable that can contribute to the result of the study. Also, some threats to the internal validity include the subject characteristic that can be found during the selection bias. So the groups may have been different from the start, and if you were testing instructional strategies to improve reading and one group enjoyed reading more than the other group, then this may improve more in their reading abilities because they enjoy it, rather than the instructional strategies that were used. So this can be applied to the selection bias of these participants in the study. Also, the location. Perhaps one group were at a disadvantage because of their location, depending on the site of the study, as well as the instrumental decay, that the testing instrument may not have been calibrated or tested before starting the study. In addition, the data collector bias, in which the person who is collecting the data may have favors one group or some characteristic of subject rather than the other, then this may affect our selection or data collection in general. Also, the resentful demoralization of the control group, in which the control group may become discouraged because it is not receiving the special attention that is given to the treatment group, and they may even perform lower than the usual because of this characteristic in general. So once the researchers are confident that the outcome of the experiment they are designing is the result of their treatment, actually, the internal validity, then they may determine which people or situation of the result in their study can apply to the external validity of the study in general. So while for the external validity, they are the result of the study generalizability that can be applied to other population and setting, and it can come in two forms, including the population validity and the ecological validity of the study. And for the population validity, it is the extent to which the result of the study can be generalized to the specific sample that was studied to a larger group of subjects in general. While the ecological studies or the ecological validity is the extent to which the result of an experiment can be generalized from the set of environment conditions that are created by the researcher to other environmental conditions or settings. So some threats to the external validity, including the pre-test sensitization, including that treatment may only work if it was pre-test or a pre-test was given. Also, measurement of the DV, which a treatment may only be evident with a certain type of measurement that can be applied in general. So first and foremost, an experiment must have an internal validity. And if the researchers cannot be certain that the result of the experiment are dependent on the treatment, then it doesn't matter to which people or situation they wish to generalize their finding on. So the importance of the external validity is reliant on having an internal validity in much of the same way that the validity of the measurement instrument is reliant on the instrument that is being reliable in general. So some different study design in the quantitative studies include the one-shot case study design, also the one group pre-test post-test design, the statistic group pre-test and post-test design, and the randomized post-test only, and the pre-test control group, and the randomized Solomon 4 group design. So we can apply any of these tests when we are conducting a quantitative study, depending upon the factors that we are wishing to study and to examine. So when we are conducting quantitative study to develop a medication or medical investigation, mostly animals are used during the drug development phase. So why do we do this? This is conducted to understand how a drug behaves in vivo, specifically to capture the pharmacokinetic data to assess the toxicity and to assess for the efficacy of the study that is being conducted. Also, pharmacokinetic and toxicity data measure the exposure at different doses, including the absorption, the distribution, metabolism, and excretion. Also, it can define the tolerability and the safety, including the maximum tolerated dose, as well as the well-being and the tissue damage that has developed in these cases. So the duration of repeated dose toxicity study to support phase 1 and 2 trial in Europe and phase 1, 2, and 3 in the US and Japan are dependent upon the dose of the study that is to be. And this is an example of a table that we can use to instruct us on these factors which we are assessing. It commonly has 3 dose levels and the vehicle. In the low dose level, it should be non-toxic, but a small multiple of estimated therapeutic dose. Also, high dose should be sufficient to cause toxicity, but not death. And an intermediate dose can be given in order to assess for the implication of these cases. So the detailed observation of the physical conditions, the growth, the behavior, and the biomarkers can be assessed during these phases. Some of the terminologies that we use when we are conducting quantitative studies include the NOEL, the no observable adverse effect level, the HAD, which is the human equivalent dose, the MABEL, which is the minimum anticipated biological effect level, and the MRSD, which is the maximum recommended starting dose. So the NOEL is the highest dose level that doesn't produce a significant increase in adverse effect in comparison to the control group. So it also refers to biologically significant rather than statistically significant. For example, it doesn't have to be statistically significant, but rather have an impact on the factors which are studied. So distinguishing from no observed effect level may be effects in animals, for example, but doesn't have an impact on humans. So then, in which there are essentially 3 types of finding, that is in non-clinical toxicology studies, which can be used to determine the NOEL. So the first one is the overt toxicity, in which the clinical signs are apparent immediately. Also, there is the surrogate marker of the toxicity, by which the serum level, enzyme level, and the integrated pharmacodynamic effect. So the human equivalent dose is can be applied after the NOEL in the relevant animal studies which have been determined, and then they can be converted into the human equivalent dose. So for the human equivalent dose, the assumption is that the toxic endpoint for the therapeutic administered systematically to the animals, such as MTDs, are usually assumed to scale well between species when doses are normalized to the body surface area. For example, for anti-epileptic drug, the dose lethal to 10% of the rodents, and therefore can be converted into the equivalent human dose. So HAD is calculated from the NOEL in the most appropriate animal species using the body surface area conversion factor. And the most appropriate species is usually the most sensitive one, but occasionally another model is more relevant in terms of assessing the biological factors. This is an example of conversion of animal doses into human equivalent doses that can be used as a reference guide when we are assessing or conducting medication clinical trials. So converting to mg per m2 and the HIT HD, the first step is to convert an animal from milligram per kg to milligram per meter squared. So the dose is multiplied by certain conversion factors that are indicated as Km to be included in these studies. So after converting these factors by multiplying them with a certain predetermined factor, then they are divided into the Km factor for human beings. And the conversion can be conducted in a single step by dividing these factors in general. And next, we can apply a safety factor that should be applied to increase the assurance that the first dose in the human will not cause any adverse effect as a result, for example, of human bioavailability and metabolism that may differ significantly from that of an animal. Also, mechanisms of toxicity may not have been known, or that toxicity may be due to an unconditioned metabolism, or it can be difficult to detect in animals, for example, such as headache or ocular problems that cannot be assessed. So after that, we can assess the MRSD. In general, we should consider using a safety factor of at least 10, and dividing the HED by the safety factor will give us the MRSD. But in certain condition, we can increase the safety factor to have better impact on these assessing factors or the dose that we are administrating. For example, these can include inadequate dose response data, as well as novel therapeutic targets and animal models with limited utility. So these can also assess the steep dose response curve, the severe toxicity, and the variable of the bioavailability of these medications that can be conducted. So in this efficacy study, we can assess if there are any signal of desired effect relying on animal models of disease of interest, as well as these other reliable conditions. In addition, in most cases, animal studies fail to predict the efficacy in humans, and these can be attributed to factors that animals are not miniature human, but have difference in their metabolic pathways and their drug metabolism, therefore leading to variation in the efficacy and toxicity as well. Also, having inadequate knowledge of the cause of a disease means it is difficult to reproduce the human condition, as well as the differences in route and the doses of administration compared to human, and having lack of robust study design and method of randomization, such as blinding and choice of conversion therapy, and having non-placebo, for example, impact. So having a small experimental group with inadequate statistical power will have simple statistical analysis, which doesn't account for any confounding variable, and therefore may lead to failure in to follow the intention to treat the patient. So using outcome measures of uncertain relevance to the human clinical condition can therefore be indicated. And animals don't report subjective effects, and having variable duration of follow-up and needing to humanize the animal for some treatment all can be some negative impact that can be detected during these factors. So these are the issues that are mostly related to the reproducibility of the drug impact in general and can therefore have some negative impact on the medication dose. So these are the factors that can be helpful in improving the bioscience research reporting, including assessing the sample size and the allocation of treatment, in addition to the analysis of the baseline data. So some alternatives to animal testing, including having induced blueprint, having organ-on-a-chip assessment, as well as in silico studies with computer models of disease, in addition to the humans that are used as experimental subjects, including microdosing and pharmacological challenges, as well as testing using imaging studies such as CT scans. So after understanding the quantitative study, which is the most prevalent type of study, we will continue with discussing the phases of any clinical trial. So the content of the research plan should start out with sorting the data collection, and making careful comparison between copies of collection sheets to learn the differences between them. For example, putting data that are similar together in a similar manner and together within the same category. After that, we need to perform a quality control check, which is the data cleaning method, as well as having data processing, that this could be either manually or computerized process, and after preparing the tables for the analyzed data which we have conducted. So the decision on the sequence in which the table should be analyzed should be determined in this phase, as well as estimating the total time for the analysis and decisions on staff needed for the analysis, and finally estimating the total cost for the analysis to be conducted. So the formal dissertation of a process proposal should include the title that should be sufficiently detailed to inform the reader and to what we are proposing to do. This should also be followed by the introduction that can include a selective review of the background to both in the dissertation process in general. After that, it should be followed by the research question and the methodology, in addition to the design issues and the study base. And finally, we should include the time directions, whether it is a retrospective study or a prospective study, as well as deciding on the data gathering method in general. So following that, we should include any techniques for the data analysis, as well as the resources to be collected and citing the reference in which we are going to be using. So following that, we should have ethical issues considerations defined and assessing the word count with the presentation of these factors. So in clinical practice and research, it can be conducted to diagnose a disease or to treat a disease or even to prevent a disease from developing. So the clinical research is research to improve any of the above or previously mentioned details in order to have the best outcome in general. So we shouldn't fixate on a certain definition, and these are the main topic to be focusing on, which is clinical research, that is a research to improve clinical practice, and experimental medicine is an experiment where a human is the subject, and the translational research is bench to bedside and back investigation of these medications. So, how can we learn about human disease? This can be conducted on several phases, including the in vitro studies, which are cells on a dish, as well as it can be manipulated, and in vivo environment is most often lost. Therefore, treating a cell is a long way from treating a patient, but can give us a certain indication on these factors as well. There is also the animal model studies in which, for example, assessing ApoE enzyme or cancer. These can be helpful in sacrificing the animal and looking only at the tissue. Also, the animals are not human as a disadvantage for this method, and it can partially resemble human disease, but it is not exactly the same one. Therefore, the effect cannot be exactly determined in these cases. There is also the dead bits of human studies, which are tissue banks or biopsy studies. Uh, the advantage of this method is that it is the correct animal and the correct disease to be investigated. Uh, it is only the main disadvantage is that it is only studied in one time point, usually after they are dead, and therefore no intervention can be applied during this interventional method. There is also the living people experimental medicine studies. These are experimental and clinical trials that study the true disease using the correct animal with the intervention that is possible, but it has very limited options in what it can measure. There is also the epidemiology studies, which are, for example, GWAS studies, and they can be helpful in gene identification, but can only offer clues on what can be assessed or what can be determined in these factors. So the drug development include four main phases. The first one is the pre-discovery phase, that is followed by the preclinical trial studies, followed by the clinical trials, and then the scale-up manufacturing phase. Each one lasts for several years or time points in general, and therefore can depend upon the progress of the study to determine their impact in general and their implication on the study. These are some examples of the annual development of new drugs, and most of which fail to meet phase 3 study, mostly due to efficacy issues that develop during the manufacturing process. Also, there are some issues that relate to the safety as the second most important factor and to the strategy of the drug development. So only 50% of studies survive phase 3 clinical trials, and this is mostly, as I mentioned, due to the efficacy of the medication. So how can we improve the decision-making about which drug to develop? This is a complex question with a complex answer, including that we agree upon that better translation medicine is needed, better clinical research and experimental medicine, or whatever we can call not relying entirely on mice. So some tools of experimental medicine include biobank studies in which human tissues are used, also imaging facilities and genetic studies that can be implicated, and clinical research facilities that are also assessed. So for biobank studies, the dose of the disease may express the drug target. We may even include the tissues, not just the blood of the participant sample, and it needs a rigorous initiation and linkage to clinical data with appropriate governance. This is an example of a post-mortem brain studies for patients using imaging technique for the development of these factors. So in imaging, we can assess both the pharmacokinetic and the pharmacodynamic. In the pharmacodynamic, it can assess or detect and quantify a marker of the drug effect. Also, it can assess if whether the medication actually does anything, and trial for chronic disease are long, large, and therefore expensive to be indicated in these factors. So it is nice to have an indication that the drug may actually work, but the molecular changes that precede the structural changes, therefore preceding the clinical changes in their factors. So for example, using PET scan in receptor of occupancy studies can be helpful as an indicator in these cases. And for example, we can assess with assessing these factors or with imaging of MRI or conducting example of clinical low-tech degree studies. So for the study design, for example, we have 6 men and 6 female by defining equal gender in both groups with normal BMI that are giving BYAY and normal saline. In this example, we will conduct a crossover study that is double-blinded and randomized. And we can ask them a subjective measure. For example, did one of the two administered treatment reduces hunger and food intake or not? So this is an example of how we can use these identification in a simple type of study. So initiating the clinical research should start with defining the question and designing the study to obtain a scientific peer review securing funding. Therefore, having or preparing the study document, obtaining any required ethical approval, and any additional approvals that are required by the organization in which the study will be conducted. So the goals of conducting clinical trials is to enhance these factors or quantifying the studies in general for a better impact. So quantitative study explain a phenomena by collecting a numerical data that are analyzed using a mathematically based method, in particular using statistics. While for clinical research, it is the research that is conducted with human subjects or on materials of human origin, such as tissue, for which an investigator or colleagues directly interact with the human subject. So they are excluded from this definition, including the in vitro studies that utilizes the human tissue and cannot be linked to a living individual in general. So an important factor to consider when we conduct any quantitative research design is the causality. So it is defined as the notion that is examined as one of the main purposes of quantitative studies is to detect the actual relationship between two variables or more, depending on the study that we are conducting. So the patient-oriented research, in this type of studies, the research involves a particular person or group of people, or even uses materials from humans, for which the mechanism of human disease, the therapeutic intervention, or the clinical trial, and the development of new technology can all be assessed during these phases. So after that, we should state the hypothesis of the research, which is the research question that we are seeking to answer. So doctors, for a popular saying is that doctor putting drug on which they know little about into the bodies which they know less about for a disease that they know nothing about was a big problem when in the previous decade when they were investigating medication development. So when we are conducting a clinical trial, it has to go through 4 phases. In phase 1, these are or include healthy volunteers or patients. It is usually small in the sample size and assesses the initial safety, tolerability, and pharmacokinetic with or even without experimental pharmacodynamic endpoint. So in phase 2, these include patients and will assess a proof of concept in small cohorts and even larger population phases in phase 2b. So this type of studies confirms the safety and the tolerability as well as the pharmacokinetic in patients and explore the efficacy of these medications. While in phase 3, these are the focus only on patient participants. Also, it compares the new and the standard treatment as well as safety, the tolerability, and the pharmacokinetic and efficacy in large cohorts. So these include full randomization and double blinding, while in phase 4, these are the post-marketing studies to monitor the patients in their response to the treatment. So some of the common clinical trial design include the double-blinded, the randomized, and the placebo-controlled studies. So trials to demonstrate the superiority include the placebo study, and it is considered to be unethical to withdraw effective treatment from patients, as well as a placebo-controlled trial will provide the best evidence to sustain the claim that a drug safely and effectively treats a certain disease. So the interpretability of the result can provide evidence of the correct dose selection, the receptor occupancy, the targeted pharmacology, and the pharmacokinetic and dynamic endpoint of these factors. So some of the questions-based approach, including assessing the specificity and the sensitivity, as well as the positive and negative predictive value of these medications as well. So a question-based approach will focus on objective of assessing the safety, the tolerability, and the pharmacokinetic, as well as dynamic and efficacy of these factors. Also, these type of studies include regulatory investigational medical products and exploratory methodological studies. Also, some type of design randomization include double blinding or open label studies, as well as placebo-controlled studies can all be implicated in these factors. So the steps we need to undertake to conduct a clinical trial is first to start with the documentation, assessing the protocols as well as informed consent and the clinical investigational product development, as well as the integrated research application system guidelines and any additional materials that we will require, such as flyers, CVs, or any other indication that we require for our study. So some of the key approvals that we need to obtain is a research ethical committee approval, administration of radioactive substance approval, and gene therapy approval, and any required or specifically required product depending upon the investigations that we are undertaking. So some of the key rules in the clinical trial include the sponsor responsibility to assess for contract, submission, study initiation meeting, and study monitoring, as well as developing or creating the study team by choosing the principal investigator, the clinical trial coordinator, any research physicians required, pharmacist or statistician, and technician, all of which that we need to conduct the study. So some of the consideration during the development of research ethics is that it was based mainly on historical events that led to shaping the research guidelines that we know today. So the role of the research ethics committee is to protect the human right, to give a balanced, independent view of research that is required by regulatory bodies, and to prevent scandals in the biomedical research, and also is a fundamental remit due to participant safety and in order to ensure the best outcome for the participants in general. So the research ethics committee can be composed of laymen, clinicians, nurses, pharmacists, and any other person who is interested in the research development process. So the research ethics committee include assessing the governance and legal compliance of the research. It replaces any local checks of legal compliance depending upon the study that we are assessing, as well as ensuring that organizations can focus on the capacity and their capability buildings. So the current RIC system includes simultaneous processing with written clarification and approval for any amendment, as well as a standardized operation procedure. So when do we need to apply for research ethical committee approval? This is conducted when we are having patient participants in the research study, also accessing to data or organ or tissue from the Ministry of Health banks, and assessing, accessing or using their permits, such as labs or imaging facilities, and these related aspects. Other review bodies that we need to obtain approval from include the Confidentiality Advisory Group, the Human Fertilization Authority, confirmation of compliance with long ionizing radiation use, depending, of course, on the medication or the intervention that we are applying. So before applying for any of these approvals, we need to plan the research by identification of the site of the study, as well as potential participant and resources needed for the study, considering any assistance that is needed, ensuring sufficient funding that is available for the study, as well as if the study takes place or uses any certain facility, we need to discuss this with the team and include this in the ethical approval that is required. So the integrated research application system is a single system for applying for approval for healthcare research, for example, in the UK. It enables us to enter information about the project one time only instead of duplicating the information in separate application forms. Also, it filters to ensure that the data that are collected and collated is appropriate to the type of the study, and it will help in meeting the regulatory and governance required for these factors. So this is a picture for the IRS that is to be used in certain countries and will have main ethical consideration with scientific justification and methodology with the recruitment process that we must include details for on exactly how the participant will be identified and approached and recruited in general. There is also the advertisement section in which it is important that to submit approval for every advertisement format that we intend to use. For example, if we are using posters, screens, adverts, as well as email, we need to identify this during the selection process. Also for the advocacy by providing evidence that arrangements are in place to ensure the inclusion in our research for those who are not fluent in English, for example, and the data monitoring committee that need to be in place for phase 3 studies only, and having audit studies as well to be included for the approvals. So the IRS should also include information about sponsorship in which all healthcare research must have designated sponsor before an ethical approval can be obtained. Also, the investigators leading the trials or healthcare research employing organization should act as a sponsor, and the sponsor should take on the overall responsibility for the initiation, the management, and financial guarantees for the study. So, delegation of responsibilities agreement between the associated trusts should also be included, and adding the site information and the clinical trial manager name and details for contact information is also required. In addition, having indemnity or insurance assessment is required for any human intervention study, and approval is project specific and must therefore be sought before any ethical application. So this site applies to their own indemnity for Clinical Negligence Act, and therefore the colleague indemnity should provide both negligent and non-negligent harms. So these are the instruction of including the compensation information and any other required info as well. So for the sponsorship approval, having copy of the research facilitator and governance manager or clinical trial manager should include the research protocol, the completed IRS form, and the insurance project registration form. So the sponsorship letter and the indemnity email confirmation should also be included, and a signed declaration of electronic authorization before proceeding to submitting the application is required. But some of the common reasons for a provisional approval include spelling mistake and types. Also, anonymized tissue samples and data sets should be used whenever possible, and unless a permission is sought from the case confidential advisory group, then discrepancies between the application form and the protocol should also be included in the participant information sheet. Also, some common reasons for provisional approval including too much technical information, insensitive language, clear procedure on what part routine clinical care is to be included, and diagrams of what happens to the participant, as well as follow-up that should be clearly described, and using some visual terms such as instead of using 10 ml of blood, using 2 teaspoons. Also having separate information sheet for control groups and healthy volunteers. In addition to issues with the consent forms, such as specific consent forms for genetic research and consent to use samples of any future research that may take on a place, and asking permission to inform their GB on their taking part of the study. So we have reached the end of our first session. If you have any questions, please do send them on the chat, or you will start with the next session soon.
السلام عليكم. صوتي واضح يا جماعة؟ الصوت واضح بالنسبة لكم؟ اوكي تمام، نبدأ بإذن الله. Okay, in the first session, we will discuss the topic of clinical practice and research. What is the relation between clinical practice and research? Clinical practice and research go hand in hand. Research helps to improve clinical practice by providing evidence-based guidelines and treatment approaches. However, it is crucial to maintain research ethics throughout the process. Research ethics is very important. Research ethics ensures the participant's safety, privacy, and informed consent. Also, the research ethics promotes the integrity and the transparency in data collection and during analysis, leading to reliable and trustworthy research outcome. Research ethics is very, very important. Research ethics is now a new discipline in which it is the frame of research. Conducting research is essential to be guided by the research ethics, especially the research ethics principles of the Declaration of Helsinki. Upholding research ethics is very essential and very important for the advancement of clinical practice and the overall being of patients. Why is research ethics important? Is it important for the science itself, or for the scientist, or for the research participant, or the public, or the future, or ourselves? Research ethics basically target and address the protection of the research participant, the welfare and rights of the research participant. So research ethics is a discipline that mainly target the research participant, target how he is protected, how his welfare and rights are protected all over the process of research. Who is the research participant? Research participant is a living individual about whom an investigator conduct a research by obtaining data or identifiable material or private information from the subject, either through intervention or interaction. The definition of human subject is very important as it guides us all over the research process, where we need informed consent, where we need the approval of the ethical committee. So it is very important to identify the definition of human subject. What is research? Research is defined as systematic investigation, including research development, testing, evaluation. It is mainly designed to develop or contribute to generalizable knowledge. We do systematic investigation in which we put a hypothesis and then we test this hypothesis and evaluate it to generalize the results of our research to the population. What is a human subject research? A human subject research is a research involving a living individual about whom a researcher or investigator obtains data through intervention or interaction. What are the different types of interventions or interaction? Intervention means that the investigator assigns something to the research subject. It may be health education, may be a clinical trial for a drug or a diagnostic test, or interaction. What is an interaction? Face-to-face interview is an interaction. Questionnaire through the social media or the email or the phone is also an interaction. Or the researcher may obtain identifiable human material, maybe a blood sample, a urine sample, or private information. What are the examples for private information? Information about smoking is considered private information. Information about sexually transmitted disease is considered a private information. Information about the income of the subject is also considered a private information. Here, throughout the research ethics, we always balance between two goals. What are these two goals? Advancement of science and protection of subject welfare and right. Which one of them should have the upper hand? Protection of subject welfare and rights should precede the advancement of science. Advancement of science is, yes, a good privilege. However, protection of subject welfare and his right to decide and take independent decisions precede always the advancement of science. What is the historical background that guided us to study the research ethics and make it a separate discipline? Codes, guidelines, and regulation developed to guide research involving human subject failed to protect the human subject, failed to protect the human participant all over the history. So the solution was to develop research ethics and codes that we all have to adhere to it. As you can see, vulnerable groups like prisoners orphans, mentally ill were the most targeted. So research ethics was developed to protect vulnerable population, to protect the human subject, to protect the participants. Before the 20th century, there were no formal codes of research ethics. One of the famous tragedies of research ethics was the experiment of Albert Niacin, who is the discoverer of the gonococcus bacteria. He tried to develop a vaccine for syphilis, and so he injected the bacteria of syphilis in women who work as commercial sex workers. Unfortunately, they have been infected with syphilis. And he refused to confess that his experiment was the reason, and he said that it was because of the nature of their work. Another famous tragedy was during the World War II. What happened during the World War II? They used prisoners, okay, in experiments, and they were submerged in tanks filled with cold water to determine how long German pilots would survive after going through such conditions. The Nazi doctors and scientists were put on trial for the murder of concentration camps who were used as research subjects. 15 of them, 15 were guilty and 7 were hanged and 5 was life sentences. Why did the German physicians harm these prisoners? Didn't they swear the Hippocratic Oath? Yes, they did. And the first item in the Hippocratic Oath is doing no harm. But the case here is science can be corrupted by politics. Science can be corrupted by politics. So the research ethics was developed to protect the research from such corruptions. Here we are in fear of reducing the research subjects to be research objects. We must deal with the research subjects with dignity, okay? As they are human beings, we shouldn't subject them to any risks or any dangers during the research process, even if the research will advance the science. So without an adequate framework for research ethics, there will no be protection of human subject. What was the solution? At that time, the solution was to expand the Hippocratic Oath to protect research subjects. But of course, it was not enough. So here comes the Nuremberg Code with 2 main concepts. First, the concept of the Hippocratic Oath, which was first, do no harm, in addition to the concept of human rights. One of the main measures which was taken to protect the human right is the voluntary consent of the human subject. By another meaning, the informed consent. and the welfare of subject was guaranteed by the scientific value of the research, the favorable risk-benefit ratio. In addition, that suffering by subjects should be avoided. The Declaration of Helsinki was developed by the World Medical Association in 1964. It provides guidance for physicians and participants in medical research. The Declaration of Helsinki is updated every now and then. What is the main principles of the Declaration of Helsinki? The Declaration of Helsinki indicates that the well-being of subject should precede the interest of the science and society. Physicians should obtain the subjects freely given informed consent in writing, in addition to the approval of the Ethical Review Committee. The Ethical Review Committee is no longer an option, it is a must during conducting research. Before starting data collection, you must get the approval of the Ethical Review Committee or the Institutional Review Board on your research. What are the problems during conducting research? What can make the research unethical? The main problems during conducting research are lack of the informed consent, use of vulnerable population, exploitation of vulnerable population, withholding information or treatment, putting subjects at risks. When you underestimate risk and overestimate benefits, it's a very common problem among researchers. Deception and violation of rights are among the ethical problems during conducting a research. In 1974, the Belmont Report was submitted, and it sets 3 fundamental ethical principles. What are the 3 fundamental ethical principles that were set by the Belmont Report? Number 1, respect for persons, which means the autonomy and the right of the human subject to decide whether or not to participate in the research. Number 2 is beneficence and non-malfeasance, doing good for the subject and avoiding any harm. Number 3 is justice. Of course, during the Islamic era, all the ethical principles known in modern history were used, which include respect for persons, non-malfeasance and beneficence, and of course, justice. All of these principles were included in the Islamic rules. What is the meaning of respect for persons? What do you mean by respecting someone? Okay, what do you mean by respecting his personality, his culture, his traditions? Is it enough? No, it is not enough. Respect for persons comes mainly from giving him the right to take independent decisions. Okay, so autonomy and respect for persons are closely linked together. There is no respect for persons without autonomy, without the right of the subject to take independent decisions. Also, respect for persons includes very important principles, which is the right of privacy and confidentiality. What is the difference between privacy and confidentiality? If anyone knows the difference between privacy and confidentiality, please write it in the chat box. If you know the difference between privacy and confidentiality in research ethics, please write it in the chat box. The difference between privacy and confidentiality, privacy is always in terms of setting. We set in a setting that provide privacy. Okay, confidentiality is always in terms of data. You are responsible for the confidentiality of the data of the research subjects. Okay, also respect for persons requires that we have to go through the process of the informed consent. Also, respect for persons requires that we conduct research in a convenient environment, which reflect also the privacy during research conduction. Respect for persons gives the human subjects the right to choose. And this is guaranteed by the informed consent, by the privacy and confidentiality protections. It allows people to choose for themselves. It respects the privacy. It protects the sensitive data. Additionally, extra protection measures are taken for individuals with limited autonomy or for vulnerable groups, as, for example, disabled, mentally ill, prisoners, orphans. Extra protection measures are taken for individuals with limited autonomy through taking their family consent. What is the beneficence? Beneficence means first, do no harm, okay? And also meaning that doing the good, the benefit for the human subject. Here we balance between two goals, maximize benefits as much as we can and minimize risks as much as we can. What are the different types of risks that may be faced during conducting a research? First of all, physical risks, which means physical harm to the subject, or social harm, for example, social stigma, which is common among HIV patients. Psychological harm, maybe in the form of anxiety or shame. Material or money-wise. Any personhood being violated is considered a type of risk. Even inconvenience or time loss is considered a type of risk during conduction of a research. What are the components of risks? Risks is defined as in terms of two components. What are these two components? Magnitude of harm and probability of harm. How much or how frequently does this harm happen, or does this risk happen? Magnitude of the harm, which ranges from slight discomfort up to death. So here the risk is described in terms of two components, the magnitude of the harm and the probability of the harm. For example, %2 probability of causing death may be considered very risky, while 60% probability of causing dizziness or headache may not be very risky. So it is always a function of both probability and magnitude. What are the levels of risks? Levels of risk ranges from minimal, above minimal, and too risky. What is the unaccepted level of risk? The unaccepted level of risk is too risky. What about benefit? Here, benefit is a function of opportunity rather than probability. So in benefit, we don't talk about the magnitude or the frequency. We are interested in the opportunity of this benefit rather than its probability. For example, a study with a small probability of a great benefit, such as cure from a fatal illness, is considered more beneficial than another one with a high probability of a minimal benefit. The benefits are either benefits to the research subjects or benefits to the society. Please take care that payment or incentives should be not assessed as potential direct benefit to the subject. And also, please don't overpromise benefit. Don't overestimate benefit. Any incentives given to the research subject during research is given as a compensation. A compensation, for example, a working day lost in his work, okay? This is the type of incentives that is given during a research. The benefits to the research subjects are either direct, for example, treatment, increased knowledge assisting in diagnosis, or indirect, what we call collateral, for example, extra supervision, more access to medical care, or unplanned benefits. Beneficence and non-malfeasance. How can we judge the beneficence and non-malfeasance? It is judged by a favorable risk-benefit ratio. You must compare the risks to the benefits. You must maximize the benefits and minimize the harms. Use best possible research design to minimize harms to research subject. Additionally, use qualified investigators and monitor the safety during conduction of your research. As we said before, we should compare between benefits and harms, and we should avoid any unnecessary harm for the patient or the subject. Even slight discomfort is considered a type of risk. And we should maximize the benefits to the participants and the society as much as we can. Justice, there must be fair distribution of benefits and burdens. There must be protection of vulnerable groups, and we said before, vulnerable groups as old age, orphans, prisoners, people with disabilities. Also, the research must be relevant to the community, okay? And also could provide benefits to other populations. Here are examples for vulnerable populations: pregnant women, children, elderly, mentally disabled, sick persons, unconscious persons, prisoners, persons with little or no education, poor persons. All of these are important groups among vulnerable populations. The moral test of any society is how it cares for the people, or how it takes care of the vulnerable population, like children, like elderly, like sick. Okay, also justice means equitable distribution of burdens and benefits. You must ensure that no one group take on the burden of the research or the benefits of the research. And this can be managed through blindness and through randomization of the selection of the research subjects. Also, fairness in selection of human subjects. Avoid choosing groups based on compromised positions. Don't involve groups unlikely to benefit from the subsequent application of the research. And this is very, very important during conduction of international research, or what we call safari research. When you sometimes international organizations may conduct research in other countries, in other developing countries, and these populations in these countries will not benefit from this research. Okay. Developed countries testing drugs in developing countries. As we said, the safari research or the international research has a lot of ethical debate. Okay, they decide to leave their countries and conduct the research in developing countries due to unfavorable conditions in their own countries, like strict regulatory restrictions, high costs, small populations, low enrollment rates of the human subjects. So they go to poor countries and conduct their research. However, there are many fears or problems that faces the international research, mainly in the form of exploitation of human subjects. What is the exploitation of human subjects? It means unfair distribution of benefits of research, in which developing countries assume all the risk and the developed countries take all the benefits. They do research on diseases that only exist in developed countries, so the developing country will not benefit from the results of the research. Also, tested drugs will be sold only in developed countries because they are the one who can afford buying these drugs. So, how to achieve fair benefits in international research? To achieve ethical research, all ethical codes and principles should be applied. Mainly respect for persons, beneficiaries, justice. Research is a privilege, not a right. The well-being of participants is a priority and must always precede the privilege of research and advancement of science. Now we will proceed to know more about the Research Ethical Committee composition and functions. As we mentioned before, that the Declaration of Helsinki stated that in order a study in order to be ethical, there must be an approval from the Research Ethics Committee before starting the implementation of the research. What is the aim of the Research Ethics Committee? The main aim of the Research Ethics Committee is to provide understanding, okay, of your protocol, your research protocol, and whether approve or disapprove your research, or it may require modifications of your research. Research Ethics Committee, REC, or the Institutional Review Board, IRB, both terms are used. What is a Research Ethics Committee? It is a committee formed by institution in order to review, approve the initiation of a research, okay, involving human subject. So Research Ethics Committee is mainly targeting human subject research. What is a human subject research? As we discussed before, a human subject research is a research conducted on a living individual in whom the researcher obtain data through intervention or interaction, or obtain identifiable material like a blood sample or a urine sample, or collect private information. What are private information? Private information like information of the income, about the income of the human subject, information about sexually transmitted disease, about the smoking status, about the addiction status. All of these are categorized as private information. What is the main primary purpose of a Research Ethics Committee? The main primary purpose of a Research Ethics Committee is to assure the protection of rights and welfare of human subjects. Okay? Why a Research Ethics Committee is needed? Why we need someone watch over us? Because of the history of abuses that happened in research activities along the history, for example, the Nazi experiment. Also, the growing concerns worldwide on the need to put in additional safeguards for protection of human subjects. One of the very important is the Declaration of Helsinki. The increase in research involving human participants, the progressive rise in the number and types of human subject research. Sometimes it is a crucial requirement for funding by international organizations. In order that you obtain a fund or a grant, you must have an approval from the Research Ethics Committee on your research. We always balance between these two goals, advancement of science and protection of subject welfare and rights. Which one of them should precede and which one is a more priority? As we said before, protection of subject welfare and right is the main priority. It should precede the advancement of science. Why do I need an REC to review my protocol? First of all, for the objectivity of your research. Very common that investigators underestimate the risks, okay, and overestimate the benefits of what you believe in. Also, for the social context and building the trust and encouraging people to participate in research. Also, to declare any conflicts of interest and maintaining public trust. Also, the revision by the Research Ethics Committee makes the research studies better. How? Sometimes they require some modifications on the study design and protection of subjects, which enhance the quality of the research and make it better. Okay, and of course, this will reflect on the results of this research. Also, obtaining the approval of the REC enhances the researcher reputation. Additionally, increased requirements for ethical approval in different scientific bodies. Now, most of the universities requires the approvals of the Research Ethics Committee before their approval on any research. For example, for MD and master thesis, more likely to get published in good journal. Most of the international journals recently requires the document of the approval of the REC before submission of your research or during the submission process of your research. If you don't have the approval of the REC with its serial number and date, you cannot submit your research in good international high impact journals. Also, to get funding and grants. International guidelines requires that an independent committee perform an ethical and scientific review of medical research. When to apply to the Research Ethics Committee or the Institutional Review Board? When you have to apply? You have to apply to the REC before any research activity, at least 2 weeks before meeting date, and please allow at least 1 month for full board review. A very important rule is that there is no post-conduction approval. What if I need a post-conduction approval because I didn't know this rule and I have started in data collection before the approval of the Research Ethics Committee? In this case, you will seek ethical clearance from the committee. The application. The application to the REC have to cover the following items. What are the items that should be covered during application to the Research Ethics Committee? First of all, subject selection. You must describe how are the subjects that will be recruited in your research will be recruited. Where will they be obtained from? Are the subjects being selected for any specific characteristics, for example, age, sex, race, religion, social or economic qualification? And if yes, explain why. The second item that should be covered in your application is the procedures. What will you exactly are going to do to the research subject? In addition to the methodology, measurements, education, training. Also, how long will each session last? And if you are using a questionnaire or a handout, please include copies with each copy of the application. If there is a questionnaire will be included in your study, the research ethics committee must review it. Where will the study to be conducted? Okay. All of these questions must be answered during the application. Also, the third item that should be covered during your application is that, are there any specific risks to the subject? The risk-benefit ratio. And if there are any specific risks, what are these risks? And what are the potential benefits that will return to the subject to justify these risks? Either direct or indirect benefits to the subjects. The item number 4 is the confidentiality. You must mention how are you going to protect the privacy of the subjects and how are you going to maintain the confidentiality of identifiable material. How are you going to take measures to store your data and where are you going to store it and the duration and descriptions of person who will access the data and the method of destroying the data after being completed. Also, you must put a copy of the informed consent during your application, and in the informed consent, you must mention the information that will be provided to the subjects about the study. How will the subject informed consent will be obtained? Okay, and the consent form should be written at an appropriate level for the study population, avoiding complicated technical or medical terms. Also, the item number 6 is additional protection measures. Additional protection measures are mentioned when you are going to recruit vulnerable populations. For example, pregnant women, prisoners, children. When you are working on vulnerable population, you should mention what are the extra protection measures that is going to protect these vulnerable populations. Also, is there any conflict of interest? It should be mentioned during your application. These are the minimum 7 items that should be covered during your application. Now, what are the minimum essential documents that are required for the Research Ethics Committee application? This is a list for the minimum requirements of documents by the Research Ethics Committee. Number 1, you should provide a signed and dated application form by the principal investigator and all the co-investigators. Additionally, you should provide a full protocol. You should provide the informed consent. Also, the CV for the principal investigator and all the co-investigators. Any additional tools for the study should be provided. For example, if there is a questionnaire or a checklist or a guide. In case of clinical trials, safety reports and previous studies should be provided. Finally, a signed researcher assurance agreement should be signed. These are the list of the documents that are required by any research ethics committee. What is the application must cover? The application must cover the social value of the research, why it is important for this community. Is there community partnership or not? To ensure and assure that the research will be accepted by the community. Is this research valid or not? Is there fair subject selection or not? Is there favorable risk-benefit ratio or not? The independent review, no conflict of interest between the principal investigator and co-investigator and any member in the research ethics committee. Also, the informed consent, including the essential elements of the consent, such as the purpose, the risks, the benefits, the compensations, the alternatives, okay, the voluntary participation of the human subject. All of these elements should be stated in the informed consent. And of course, the informed consent is a very important requirement to assure the respect for human subjects and the right of autonomy. What is the composition of the Research Ethics Committee or the Institutional Review Board? The Research Ethics Committee consists of at least minimum 5 members. How are the members of the Research Ethics Committee are selected? They are selected according to the following criteria. First of all is their qualifications and experience. Minimum, at least 1 member has to have the scientific background of the discussed or of the protocols that will be judged. Also, the Research Ethics Committee must be represented by men and women. And there must be a community representative. Why a community representative? To reflect the acceptance or the refusal of the community of the research topic. Of course, there are minor variations between guidelines on composition between different committees. Who is the chairman of the REC? Who is the boss? Who is the head of the REC? Has it to be the president or the dean of the institution? No. Not the president, not the dean, but it should be a senior professor, well-respected, who has the time to be involved and can be responsible for independent decisions. This is the criteria of the head of the Research Ethics Committee. What are the possible REC decisions? What are the possible REC decision? Approval of the study is for how long? According to the type of research, it may be for 1 year, okay? And maybe less according to the level of the risk. What about non-human subject research? Non-human subject research is a research that doesn't involve an intervention or an interaction. It doesn't obtain identifiable materials or private information. What happens in case of non-human subject research? In case of non-human subject research, the chair or the vice chair makes the decision. No review by the full board of the REC. Additionally, there is no informed consent. What are the frequent problems that face the research ethics committee during the application? The most common problems are incomplete or insufficient description of purpose, methods, procedures, subject selection, incomplete coverage page, lack of contact information, typing errors, inappropriate language on the informed consent. For example, if the principal investigator used two technical terms that the subject cannot understand, research-related documents are not included in the application, or the proposals are delivered at the last minute. What are the possible actions of the Research Ethics Committee? The Research Ethics Committee has the right to approve or disapprove or request modification to research proposals. In addition, the Research Ethics Committee has the right to review ongoing research projects and has the right to observe, monitor, and audit ongoing research projects if necessary at any time. Also, it has the right to suspend or terminate previously approved ongoing research project if the committee finds any violations during conduction of the research. Now, we will move to the most basic types of research misconduct. What are the most basic types of research misconduct? As you know, scientists have a critical mission to discover, explain, and contribute to human welfare. Scientific research builds upon the knowledge of others and builds upon the shoulders of others. So scientists should rely on truth and the credibility of other researchers. Occurrence of research misconduct has many complications and many consequences that may involve the participants, the co-workers, the institutions, the sponsors, the journals. What is a research misconduct? Research misconduct means that you do research or you conduct research that doesn't include honest error or difference of opinion. What are the main types of research misconduct? The three main types of research misconduct are fabrication, falsification, and plagiarism. What is the difference between fabrication, falsification, and plagiarism? First, fabrication. What is the meaning of fabrication? Fabrication means that you make up data or results and recording or reporting them. By another words, inventing non-existent data. For example, creating records of interviews that were never performed. What is falsification? Falsification means manipulating research materials, equipments, or process, or changing or omitting data or results such that the research is not accurately represented in the research record by another, meaning changing or misreporting data. What are the examples for falsification? Substituting one subject record for that of another subject, altering dates or altering results of lab tests. What is plagiarism? Plagiarism is simply copy and paste. Copy and paste without rephrasing the words that you take, or without giving appropriate credit by writing the reference or the source of your words. In conclusion, honesty must be assured to maintain trust. Trust always innovation. With innovation comes knowledge. With knowledge comes productivity. With productivity comes opportunity. With opportunity comes accountability. And finally, accountability requires honesty. We finished our first session. Please, if you have any questions, write it in the chat box. If you have any questions, please write it in the chat box. Okay. Okay. Thank you all. We will have a break for 15 minutes inshallah. Okay. Break إن شاء الله لمدة 15 دقيقة. Thank you very much. Okay, we finished our break. Now we will return to our lecture. This session will discuss the qualitative research. 1 second, I will share the presentation. Can you see the presentation? Is the presentation clear and is my sound clear? Okay, thank you all. Qualitative research. What is qualitative research? The two main types of research are quantitative research and qualitative research. Quantitative research is the research used to quantify the distribution, the presence, and the size of an association or a relation between certain variables, most commonly an exposure and an outcome, a dependent variable and a group of independent variables. The quantitative research provides answers to questions that can be counted and expressed in number. Most of the epidemiological and biomedical research are quantitative research. What about the qualitative research? The qualitative research mainly involves the exploration of variables, the exploration and identifications of problems, the insight into nature of causes and into consequences of problems. Qualitative research is very commonly used in social research. What is a qualitative research? Qualitative research usually seeks to understand a given research problem or a topic from the perspective of the population that it involves. For example, if I'm talking about a research about addiction, I will go to addicts and ask them what triggers you to use and abuse such drugs. It is very effective in obtaining culturally specific information about the values, the opinions, the beliefs, the social context of particular populations. Also, it provides the human side of an issue. You go and talk with your target group directly, okay? And so it often discuss contradictory behaviors, beliefs, opinions, emotions, and relationship of individuals. Most commonly, we use qualitative research if we have a shortage of information about a certain topics. So you have to explore it first. Explore it by using a qualitative research study design. Here is a comparison between the quantitative and qualitative research. From the analytical objectives, the quantitative research quantifies the variation to predict the cause-effect relationship. It describes the characteristics of a population. The qualitative research describes the variation and explain why is this relationship coexist. It describes also the individual experiences and the group's norms and their justifications and their answers. From the general framework perspective, the quantitative research seeks to confirm hypotheses about a phenomenon. It uses rigid instruments and categorized responses to questions. Quantitative research is highly structured. This is why we use data collection tools as questionnaires, as surveys, as structured observations, what we call checklists. However, on the other hand, qualitative research explores phenomena. They use more flexible instruments. They use more flexible data collection tools, for example, semi-structured methods as in-depth interviews, focus group discussions, participants observations. All of these tools allows flexibility, allows that the participants says his opinion. In terms of the question format, quantitative research use close-ended questions, while qualitative research use open-ended questions. The data format for the quantitative research will be in the form of numbers, okay, an Excel sheet, okay, spreadsheets. However, qualitative research is textual. It is obtained from audio tapes or video tapes or field notes. Which is more difficult, quantitative or qualitative research? I think that qualitative for any researcher is much more difficult in analysis than the quantitative research. Quantitative research is much easier from the analysis point of view. For example, this is a research about smoking and lung cancer. Epidemiological research has established the association between smoking and lung cancer. In this case, what is the role of the qualitative research? What is the role of the qualitative methodology? Its role will be mainly to express or explain the power of tobacco companies and advertising, the reason why people continue to smoke despite the evidence of the harm of the smoking. Most of the people, or almost all the people who smokes know very good that smoking is very harmful to their health. Despite this evidence, they smoke. The qualitative research will help to explain the social meaning of smoking, for example, among women and among young ages, and even among children. Data collection techniques and tools. There are many types of data collection techniques and tools. The most important types of data collection techniques are using available information, which is a record review, observing, interviewing, questionnaires, focus group discussions. We will discuss each type of data collection technique in the following slides. First of all, using available information. How can you use available information? And what is the meaning of using available information? These are data obtained from health information system, for example, services, statistics, vital statistics, census data, unpublished reports. The main advantage of using the available information is that it is cheap and can allow examination of trends along years. And you can compare between different settings. What is the disadvantage of using available information? First of all, it may be very difficult to access. If there is incomplete information, you cannot do anything about it. For example, there are 10 variables and you want more variables, you will not be able to obtain it. It could be outdated. Okay, the second data collection technique is by observation. What is observation? Is that you, in a systematic way, you select, watch, and record the behaviors and the characteristics of subjects, objects, or phenomena. For example, scales, watches, checklist. Observation is very commonly used during audit in hospitals as a data collection technique. What is the advantage of observation? It provides more detailed information on facts. It is very reliable. However, there is ethical issues around the ethics of the observation. There is observation bias, that there is difference in the recording of the observation between the different researchers, and it needs training and skills. Questionnaire. Questionnaire is sometimes referred to as interviewer or self-administered questionnaires. Questionnaire is a document that contains questions that are needed to be answered. What is the advantage of questionnaire? Questionnaire is one of the most very common data collection techniques. The advantage of questionnaire is that it is less expensive. It can be anonymous. You don't have to write your name. One of the disadvantages of the questionnaire, it is difficult for illiterate persons who don't know how to write or read. It has low rate of response. Its response rate is weak. There may be misunderstood or misperceived questions, so it may cause a bias in the response. The next data collection technique is through interviews. What is the meaning of interviews? Interviews meaning oral questioning of respondents. Interviews can be conducted with great flexibility. It is a more flexible technique than questionnaires. What are the different types of interviews? There is two types of interviews. First is in-depth interviews, which is used in qualitative research, and the second type is structured questionnaires, which is used in quantitative research. What is the difference between in-depth interviews and structured questionnaires? In-depth interviews are highly flexible, and it discusses a list of topics. The sequence of topics will be determined by the flow of the discussion, and it targets only a small number of participants. On the other hand, structured questionnaire is less flexible because the questions are more or less fixed. You must follow the standard sequence of the questions, and the good news that it addresses or target large number of participants, and this is a strength point in the structured questionnaires. What about the focus group discussions? What is a focus group discussion? A focus group discussion is a type of data collection technique that allows a group of nearly 6 to 12 participants to freely discuss a certain subject with the guidance of a facilitator or a moderator. Focus group discussion requires quick answers to specific questions. There are 3 persons who manage the focus group discussions. Mainly, the investigator and the moderator and someone who record the session or write down the notes. The focus group discussion discuss feeling, attitudes, perceptions. Researchers can learn of the vocab and the thinking pattern of the participants. It requires a moderator and 6 to 12 participants, note takers, and questions are asked according to guideline, which is called the topic guideline or the topic guide. Group synergy and motivation of the people to talk and express their feelings and their opinions and their perceptions is an important skill to be present in the moderator in order to moderate the focus group discussion. What is the advantage and what are the limitations of the focus group discussions? One of the main advantages of the focus group discussion is to obtain in-depth information on concepts, perceptions, and ideas. By another words, obtain group responses, especially in topics that we don't know thing about it. Also, to develop research hypotheses and then evaluate this hypothesis in order to formulate appropriate questions for structured questionnaires. If you want to develop a structured questionnaire and you have no idea about the items that you are going to include in this structured questionnaire, so you have to conduct a focus group discussion to obtain the necessary information that you will ask about it in the structured questionnaire. Focus group discussion explains and interprets results. What is the main limitations of the focus group discussion? First of all, it is expensive. It is time consuming. It needs skilled researchers in the focus group discussions. Here are some uses of the focus group discussion. It supplements information on knowledge and attitude and practice. Yes, it is commonly done in CAP studies. It helps in developing the appropriate message to be used in health education after discussing all the options with the target audience. It determines the reaction to information, education, communication material. Once you have developed or you have created the health education material, you can pilot it through a focus group discussion and know the opinions and the modification needed to be done on these health education materials before scaling it up. It can explore topics where there is much debate on it. For example, homosexuality, sexually transmitted disease, addicts, street children. What are the different types of data collection techniques and the corresponding tools for each type? First of all, available information. What is the tools for available information? You can use checklist, data compilation forms. Second data collection technique is observations. What are the tools for observation? You must have sense, of course, skills, of course, paper and pen to document on it. You may need watches, scales, or checklists. The third data collection techniques is interviews and questionnaires. And here's the tools that you are going to use are the questionnaire and the interview guide or the recorder. In case of focus group discussion, you will need a focus group guide. Combining different data collection techniques. One of the best approach during research is that you combine different data collection technique. You can use focus group discussion together with questionnaire, together with observation. What is the advantage of combining different data collection techniques? It reduces the bias. It gives more comprehensive results, in addition to giving better understanding of the topic. For example, it has been observed that children between 1 to 1.5 years who should have already started to eat have unsatisfactory food intake once they fall ill. A study could be designed, using mixed data collection technique through the following stages. First, focus group discussion with 2 to 6 group of mothers, or in-depth interviews with 10 mothers to find out nutritional behavior during illness of their children. Then you can use a questionnaire or observation to test relevant findings that you have find from the exploratory study. In case of questionnaire or observation, here it can be done on a large scale. Then again, you will do a focus group discussion with women in the study area to discuss findings and possible questions arising from the survey for sake of developing the best or selecting the possible and the best solution. In this case, you have used a mix of different data collection techniques. What was done here, the first part focused on the most relevant issues and would help to phrase the questions of the questionnaire. Once you have known the most relevant issues, you can write down the questions that you can use in the questionnaire. The second part used to find what percentage of mothers follow different practices in the form of figures, in addition to the reasons for the behavior, and whether certain groups of children are a higher risk or not. The final part, which was the focus group discussion done to discuss the results with the mothers, will provide feedback on major findings of the survey. In order to know if the result you have obtained makes sense to the mothers or not, it have certain areas that if there's certain areas that have been overlooked while interpreting the data or not, the focus group discussions will help you to do so. Choosing the type of research methodology, whether quantitative or qualitative research, will depend on what do you want to know. What is the feasible feasible methods. Where, who, what, how often, okay? These are questions that you should ask yourself before deciding the type of research that you are going to apply. A quantitative research is always descriptive in terms of who, how many, where, when, and how often. It is analytical. It provides us with the cause-effect link. And it is applied, especially if you are testing intervention and measuring the degree of change before and after the intervention. The quantitative methods on their own don't offer sufficient understanding of the complexity of the relationships between the different factors, which have an important role in health and disease. So in this case, if you don't understand the link, if you don't understand the association or the relation between the different variables, you should go to a qualitative research. The qualitative methods help to explain the factors that influence health and disease. It makes the researcher understand how individuals and communities understand the health and disease. It answers the questions like, why did it happen in that context? Why do some participate and others do not? How do professionals exert their power? So justifications, explaining, understanding are the main terms targeted by qualitative research. How can you integrate methods? How can you make a mixed type of research? How can you mix quantitative and qualitative research? First of all, you have to match the research methodology to the type of the research question you have chosen and the nature of the problem being investigated. So it depends on the type of the research question and the nature of the problems that you want to explore. Here are some examples of mixing methodologies. For example, you do a qualitative preliminary research before the quantitative to generate the hypothesis. Or you do quantitative before the qualitative to guide how you will do your sample. Or you do quantitative followed by qualitative to help to interpret your findings. Or you do qualitative followed up by quantitative to test generalization of your results. Designing a questionnaire. A very important task is to know how to design a questionnaire. What is a questionnaire? Questionnaire is a tool for collecting information to describe, compare, explain knowledge, attitudes, behaviors, or socio-demographic characteristics on a particular target group. Questionnaire is very common to be used as a data collection tool during conduction of research. What are the different types of questionnaires? It may be self-administered, may be through mail or personal contact. It may be through a telephone interview or in-person face-to-face interview. What is the advantage and disadvantages of questionnaire? One of the strength points of a questionnaire is that it is simple, cheap, completed whenever it is suitable for the participant. It can be administered to many persons simultaneously at the same time. time. It is standardized because of written instructions. It can support confidentiality. And in addition, there is no interviewer influence. But what are the main disadvantages of questionnaire? First of all, it requires a certain level of education of the participant. The participant should be at least can read and write to understand your questionnaire. Unfortunately, it doesn't include the physically disabled, people who has visual impairments, for example. The response rate for questionnaire is much less than face-to-face questionnaire. For example, you may distribute about 100 questionnaire, only you receive, for example, you receive response for 40 questionnaire, or the questionnaire may be incompletely, not completely filled by the participants. Also, some questions may be understood or misunderstood. Also, among the advantages, these were the advantages of the self-administered questionnaire. What about the interview questionnaire? It is good for illiterate people. It's good in case of disability, especially visual impairment. It is good that it traces events and refresh memory by social calendar. Okay. However, there may be missing or inappropriate responses by the interviewer. In case of self-administered questionnaire, but here in the interviews, completeness is much more better than self-administered questionnaires. What about the disadvantages of interviews? First of all, interviewer bias. There is a bias between the way that an interviewer asks the question and another interviewer asks the same question but in a different way. It needs more resources. Only short questionnaires, especially on phone. It's a sort of difficult in case of sensitive issues. For example, if you are asking about the income, if you are asking about sexually transmitted diseases, okay, it may be difficult for sensitive issues. What about the questions or the items? The questions or the items are the focus of any survey or questionnaire. It is crucial to know how to ask the questions in both written and spoken forms. The way you ask the question determines the answer you will obtain, and this is important to standardize the way in which the questions are asked. What about the stages in designing a questionnaire? First of all, you must decide what are the research questions and objectives. Then review the current literature to identify already available validated questionnaires. You should identify the population and sample you are targeting. You should list the variables to be collected, the different variables, for example, age, sex, education status, marital status, okay? You should start formulating your questions by preparing at first a preliminary draft, translate and back translate in case of English questionnaire. You should pilot your questionnaire and then modify and refine the questionnaire before distributing it on the target sample. What are the types of questions in the questionnaires? There are two types of questions in a questionnaire. First of all, open-ended questions, which allows free responses, useful for all information, especially on unknown facts, opinions, attitudes, sensitive questions. Example for open-ended questions. Could you describe what the nurse did during your first visit to the clinic? What do you think are the reasons that women in your district prefer using injections as contraceptive methods? These are examples for open-ended questions. What about closed-ended questions? Closed-ended questions offer a list of possible responses, among which the respondent should choose. You put categories, response categories, in which the research participant choose from it. For example, what is your marital status? The response categories are single, engaged, married, divorced. What is the difference between closed-ended questions and open-ended questions? The open-ended questions, issues not taken into account may be exposed. Spontaneous responses are more valid. Information in respondents' own words may be useful. However, closed-ended questions, answers can be coded and quickly recorded. For example, you say, what is your marital status? 1, 2, 3, 4. You already have the code. Data entry and analysis is much more easier for closed-ended questions. The disadvantages of open-ended questions and closed-ended questions. The open-ended questions, of course, needs skilled interviewers. Why? To get the discussion started, focus on relevant issues, note down everything that is said, and also the analysis is much more complex and requires an experienced researcher. Whilst the disadvantage of closed-ended question is that it is not easily used with illiterate respondents. If they don't know how to read and write, how they will respond to your questionnaire, which is closed-ended questions. Important information, of course, may be missed. Participants may lose interest after a long number of closed-ended questions. What are the steps taken in questionnaire development? Here are the steps. First of all, you will develop your preliminary versions. First draft will concentrate on the content. Second draft will concentrate on the formulation and how the questions follow each other. The third draft will examine the presentation. Of course, you have to pilot your questionnaire. Pre-test your questionnaire to make sure that the tool allows you to obtain the information required. This is very important during designing a questionnaire. What are the common errors and pitfalls in questionnaire design? There are two types of error mainly in designing a questionnaire. First, error in question wording, and the second type of error is in the construction of the response categories if you are using closed-ended questions. Let's see examples for the errors that happens during designing a questionnaire. Question wording. What you have to avoid? You have to avoid leading questions. You have to avoid emotionally loaded words or phrases. You have to avoid questions that assume knowledge of technical terminology. You have to avoid double-barreled questions. You have to avoid using negatives. You have to avoid vague questions. These are very important instruction during construction of a questionnaire. Here is an example for a leading question. You don't sleep well, do you? This is called a leading question. What is the correct question? Do you sleep well? Yes or no? Avoid abbreviations, for example, Y or N for yes or no. Write the complete word and avoid abbreviations as much as possible. Avoid questions that assume knowledge of technical terminology. For example, use yellow-colored skin or sclera instead of jaundice because jaundice is considered a technical terminology. Avoid using double-barreled questions. For example, have you had nausea, vomiting, or abdominal colics since your last visit? This is not clear, the yes or no for which symptom. So you have to classify it, you have to divide it, as you can see in this example. Avoid using negative. For example, are you against not smoking in public places? Don't use negatives. Don't use vague questions. Avoid using words such as many, often, occasionally, enough. Describe the quantity and specify it. Avoid errors in construction of response categories. For example, providing an incomplete list of response categories. What is your current marital status? The widow, okay, response was missed here. Response categories in this example are not mutually exclusive. It must be specific and well presented. Or avoid also response categories are not logically ordered. Please sort your response categories to be understood and well perceived by the participant. Instructions. Avoid that your instructions are inappropriate. For example, here in this case, what do you understand by stars? And you instruct him to take only one. And in this case, it is not applicable because more than one correct answer is present in this case. Don't provide the opportunity to respond yes or no before continuing with subsequent parts of the question, as you can see in this example. Here we finished our session about the qualitative research. If you have any questions, please write it in the chat box before we proceed to our next session about the experimental study tools. If you have any questions, please write it in the chat box. Okay. We will proceed now to our next session, which is about the experimental study tools. Give me 1 second and I will share and I will share the next presentation. Can you see the presentation? Is it clear for you? Tools of experimental medicine. Okay, thank you. Very good. Okay. What are the tools of experimental medicine and what is the in case of research? Okay, experimental studies. First of all, what are the different types of epidemiological studies? As you know, that epidemiological studies is classified into observational studies and experimental studies. What is the difference between the observational studies and the experimental studies? In case of the observational studies, the investigator doesn't assign an exposure to the participants. The most well-known types of observational studies are the descriptive studies and the analytical studies, such as case control and cohort, and of course, cross-sectional studies. What about experimental studies? We have three main types of experimental studies. Randomized controlled trials, what we call RCTs. In this case, it uses the patients as the units of the study or use the individuals as the unit of study. The other type is field trials, in which it uses healthy individuals as the unit of study and is most commonly used for assessing preventive agents. In addition to community trials, which uses the community as the unit of study. In experimental studies, the researchers allocate or assign the exposure to individuals or communities. For example, you assign the exposure or the intervention that may be in the form of experimenting a new drug or a new vaccine or a health education message or a health education program, okay, or a physical exercise program, for example. All the experimental studies are analytical. Of course, they are analytical. Why they are analytical? Because they study the relation between the effect of the exposure on one hand and the outcome on the other hand. How can you measure the effect of the exposure? For example, how can you how can you measure the effect of a new drug or a new vaccine? You can do so by measuring the outcome of interest and comparing between the different exposure groups, as we will see in the next slides. Again, the intervention or the experimental study design is divided into two types according to the data which is collected. If the data is collected from groups, it is called community or field trial. If the data is collected from individuals, it is called clinical trial. What is a community trial? In a community trial, the units of study are the communities rather than individuals. The community or the same people or similar people sharing the same health system, the same services. This is a community. A community may be a country, may be a governorate, may be a village, may be a school. Here, the interventions are assigned to all members in each number of communities. Here is a common example for a community trial in which treatment allocated to entire communities to compare the impact of you have added fluorine to drinking water to measure its impact on the incidence of dental care in a certain area by comparing it to another community which was used as a control. Here are some examples for community trials. Adding fluoride to drinking water to prevent dental cares, fortification of biscuits delivered to school children in order to reduce the incidence of anemia in the community, adding iodine to table salt to prevent iodine deficiency that leads to intellectual and developmental disabilities. A community trial that aimed at changing diet may include widespread information campaigns using the local or mass media. Here, the community trial is in the form of a health education program or campaign. If a vaccine trial is applied at the level of the community, this is a community trial. For example, malaria vaccine trial, which was done on a community. Okay, so all of these are examples for community trials. What about clinical trials? Clinical trials are data derived from individuals. Let's see. Clinical trials are individual-based intervention studies. They are research studies to find better ways to either prevent, detect, or treat diseases. It helps healthcare providers to find ways to improve patient care. Also, it is one of the safest ways to test new treatments in people for specific illness or conditions. So it is a safe trial. It is safe. Okay. Why do we need clinical trials? We need clinical trials because it translates results of basic scientific research into better ways to prevent, diagnose, or treat disease. The more people take part and participate in clinical trials, and the more they have trust in clinical trials, the faster we can answer critical research questions, in addition to finding better treatments and ways to prevent diseases. Also, it helps in evaluation of safety and efficacy of therapies, for which the results needs to be, first of all, non-subjective, and also it should be scientifically valid. It gives us opportunity to screen new drugs in a drug development program. So, finally, carefully designed trials are the only means to detect the usually small differences between drugs or methods of treatments or radiological procedures or lab tests or the advantage of one over another. Clinical trials are very, very important. What is the definition of a clinical trial? A clinical trial is an experiment in human beings to determine the safety and the efficacy of intervention for a given condition or disease. For example, you determine the safety or efficacy of a new drug or a new vaccine. When there is a properly planned and executed clinical trial, okay, it will assess in a very accurate way the effectiveness of an intervention in the form of a new drug or a new vaccine. The clinical trial is a prospective study, means that we start the study and observe along the time what will happen. It permits and allows the measurement of the effect of an intervention in a controlled setting. How it is controlled? It will be controlled by the investigator. The investigator, in this case, actively manipulates the exposure under the study. How he can manipulate the exposure? By deciding the person, okay, who will be assigned to the exposure. It provides the optimal strategy to avoid bias and confounding. During critical trials, you can plan your trial to avoid the different types of bias, for example, recall bias or selection bias that happens in other types of observational study designs. What are the different types of clinical trials? There are many classifications for the types of clinical trials. This is one of the basic classification of the types of clinical trials. It is classified according to the aim of the clinical trial. It is classified under treatment clinical trial, prevention trial, diagnostic trial, screening or early detection trials, quality of life trials. We will explore each type in the coming slides. What is meant by a treatment trial? A treatment trial is conducted mainly to evaluate the effectiveness and safety of new treatment or interventions for different medical conditions. Simply, you want to know if this new treatment is safe or not, or if this new intervention is effective or not. These trials involves, for example, testing new drugs, medical devices, procedures, behavioral interventions on human participants. Treatment trials mainly aims to gather all the scientific evidence to determine if a particular treatment is beneficial, better than existing treatment or not, has fewer side effects or more side effects. Treatment trials is very commonly done by pharmaceutical companies. Okay, they offer very large budgets for treatment trials. In case of treatment trials, you should follow strict protocols and guidelines. It often involves multiple phases, starting with animal phase up to human phases, okay, to ensure accurate data collection and analysis. Also, treatment trials are very essential to advance medical knowledge. Every now and then, a new drug is developed. A new drug helps patients. The survival of patients increase thanks for new drugs. In addition to improving patient care by providing evidence-based treatment options. The evidence-based treatments, the evidence-based decisions in medical care is now one of the very important and critical points. What about the prevention trials? What are the prevention trials? Prevention trials are mainly done to evaluate the effectiveness of interventions or strategies which aims to prevent the occurrence of certain diseases or health conditions. Its main aim is prevention. Prevention for health promotion, okay? Using health education to prevent certain diseases or risk factors among the targeted population is considered prevention trial. In this case, trial focus on individuals who are at risk of developing a specific condition, but have not yet developed any symptoms, for example, smokers and different types of cancers, obese and different types of health conditions, type A personality and different types of diseases that they are exposed to. Okay, so here we target individuals who are at risk of developing a specific condition, but have not yet developed any symptom. Also, prevention trials, the interventions in prevention trials may include lifestyle modification, especially for example, decreasing weight, medications, vaccines, or other preventive measures. What about yearly detection or screening trials? Why we do yearly detection or screening trials? It is done mainly to evaluate the effectiveness of tests or screening methods in identifying disease or conditions at an early stage when treatment is more effective. There are many screening tests and many screening methods every now and then are tested, okay? For example, screening methods for nutritional deficiencies, screening tools for cancer, including lab and radiological investigations, okay? How can we decide if this screening method is effective for what it was developed for? For example, if you want to know that a specific lab test will be used for screening of a specific type of cancer, we need first to evaluate its effectiveness before scaling it up, before releasing it to the market. Okay, we have to do early detection or screening trials. In this case, these types of trials involve a large number of individuals and are conducted to determine if the screening method can accurately detect the condition or not. In this case, the goal is to develop evidence-based screening program. When you conduct a screening program, you conduct it based on evidence, based on research results, okay? To detect diseases early, in addition to, it will ultimately save lives and reduce the burden of illness. It is of a great value to early detect the disease. Early detection of disease will allow early and proper management prevention of complications, prevention of consequences, and prevention of disabilities. So early detection or screening trials are very, very important. What about the diagnostic trials? What is the difference between screening trials and diagnostic trials? In this case, diagnostic trials mainly evaluate the accuracy and effectiveness of diagnostic tests or procedures in diagnosing or identifying specific diseases or conditions. In this case, what are we going to do in the trial? We will determine the sensitivity, specificity, and positive and negative predictive value of the diagnostic test in question. Participants in diagnostic trials typically undergo both the diagnostic test in addition to the gold standard test, which will be used as a reference or a benchmark to establish the true diagnosis. The results will then be compared to assess the accuracy of the diagnostic test being evaluated in the form of the parameters that we mentioned before: sensitivity, specificity, positive predictive value, and negative predictive value. These trials are very important in refining and validating diagnostic tests. It will ensure that healthcare professionals have reliable tools that will help them in timely and accurate diagnosis of different medical conditions. The outcome of diagnostic trials contribute to the improvement, of course, of patient care by enhancing the diagnostic accuracy and guiding appropriate treatment decisions based on evidence. What about the last type of the clinical trials, which is the quality of life trials? In this case, or in this type of trials, it assesses and improves the overall well-being and the quality of life of individuals with specific health conditions or undergoing certain treatment. Recently, all of the medical professionals are interested not in extending the life expectancy of patients only, but also adding to this year's good quality of life. What is the aim of someone living for 100 years without being able to talk or move in the last 10 years? So adding quality to the life of individuals is very, very important. In these types of trials, it aims to measure and evaluate the impact of interventions, such as, for example, medication, therapies, on the different aspects of the person's of quality of life. On quality of life trials, researchers in this case use validated questionnaires and assessment to gather data on the physical, emotional, social, and functional well-being of individuals, and this goes in accordance with the definition of health of the WHO, which states that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. By analyzing all these outcomes, they can determine the effectiveness of the intervention in enhancing the overall quality of life for individuals. Also, Such trials are very important because they provide valuable insights into the holistic impact of medical interventions. They allow healthcare professionals to make informed decisions, to decide the priorities of the patient's health, also their overall well-being, satisfaction, and ability to engage in daily activities in order to be productive, in order to ensure social and economic productive life, which is the ultimate goal of any health system. What are the phases of clinical trials? Here are the main phases of clinical trials. The preclinical studies at first is done, okay, and it is done mainly on animals. Then you decide to stop or proceed to the safety and dosing studies. Then you decide in phase to stop or to proceed to the next phase, which is the uncontrolled efficacy or safety studies. Then you have to decide if you are going to stop or you will design potentially positive randomized controlled trial, or you will stop or you will implement your clinical trial program. These are the main phases of the clinical trials. They are on a overlapping continuum scale, as you can see. Here it describes it in 4 phases: addressing safety, feasibility, efficacy, effectiveness, and safety. We can describe the phases of clinical trial as following. First of all is the preclinical testing, which is the animal studies. Then phase 1, we will ask, it will respond to the question if the drug is safe or not. Then the second phase, which is the uncontrolled clinical trial, is the drug effective or not. Then the third phase is the drug safe and effective in large groups of people and for longer periods of time or not. And this is the randomized controlled trial. Then the fourth or the final phase, which is the post-marketing studies. What are the long-term effects of using this drug? These are the phases of the clinical trial. Randomized clinical trial are the gold standard. They are the standard of excellence in clinical research. As you can see, here is the triangle of, or the pyramid of evidence. You can see that the non-randomized controlled trials and the randomized controlled trials are one of the designs that provide strong evidence. Then we will proceed to the randomized clinical trial. What is a randomized clinical trial? A randomized clinical trial is a type of clinical trial in which the subjects are allocated at random to receive one of the several different clinical interventions. You assign the human subject randomly to receive one of the different clinical interventions. There must be participants. These participants are allocated at random into 2 or more groups. One of these groups or one of these arms is, of course, the control arm, to receive one or more intervention, as we are going to discuss in the types of designs of randomized controlled trial. Then you are going to conduct a follow-up a long time, and the outcomes are compared to the different exposures in the clinical trial. Okay, after the break, we will discuss the randomization process, and we will discuss the different types of designs of clinical trials and the limitation of the clinical trials. Now we will take a break for 15 minutes, and then we will return back, inshallah. Okay. Okay, let's return to our presentation. What is the randomized controlled trial? This is the last slide that we have discussed. A randomized controlled trial is a type of clinical trial in which the subjects are allocated at random to receive one of the different clinical interventions. In a randomized controlled trial, there should be participants who are allocated at random into 2 or more groups. They should receive 1 or more intervention and then followed up in a time, and outcomes will be compared to the different exposures. Here is a figure describing how is randomization is conducted in clinical trials. As you can see, here is the population of the patients, in which by randomization, they are divided into 2 arms, the treatment arm and the control arm. The treatment arm in which you apply your intervention or your new drug, okay? And the control arm, you can give them what's called placebo, and then you will measure the outcomes of the intervention in relation to the different exposures. What are the main features of randomized control trial? When we talk about randomized control trial, we must mention 3 main important basic principles. These principles are randomization, presence of control group or what we call control arm, and finally, blindness. Let's start with the randomization. How can you randomize the selection of subjects? Each participant should have the same chance of receiving any of the interventions under the study. For example, each participant has an equal opportunity to be assigned to the intervention arm or the control arm. The allocation is carried out using a chance mechanism. Many software programs do this, perform this type of selection, of random selection, so that neither the participant nor the investigator will know in advance to which group each participant will be assigned, and this is very important. Let's see this algorithm which described the randomization in clinical trials. Here we get the patient information and we enter this information into a computer system. The computer will randomly assign patients into 2 or more groups to prevent any bias. The patients will be assigned in this case to 2 groups. The first group is the investigational or the intervention arm group, who will receive the new treatment, and the other group is the control group, who will receive the standard therapy. Another example for the randomization of patients. Here, each patient is allocated a number, and randomly you will choose from the patient. You will select or you will divide patient into the 2 arms, the intervention arm and the control arm. You can use many methods in case of randomization. You can use the simple random technique or the stratified random technique or the systematic random technique, whatever it is suitable for your type of research or your type or your study question, you will select the proper randomization technique. What is the advantage of randomization? Randomization gives or provides the greatest confidence that the groups are comparable by distributing all the confounding factors, for example, the known or the unknown, equally between both groups. Each study have confounding factors. If you select the subject without randomization, most probably the confounding factors will be present in one group more than the other. But the randomization in selection will ensure that the confounding factors will be distributed equally in all the study groups. Also, you will reduce the potential for bias, especially selection bias. Also, it is one of the most strongest evidence-based research that provide a relation between the exposure and the outcome or the effect. Second is the control arm. Why should we have to use a comparison group or a control group during the randomized controlled trial? First of all, to rule out the possibility of the spontaneous cure is that the patients are treated not because of the new drug, but because of chance. Also, to allow assessment of side effects by comparing both groups, the intervention arm and the control arm. How can you choose the control arm? According to a group of inclusion criteria. Here are some examples for the control arm. For example, standard care. You may have intervention arm, and opposite to it, the control arm will receive the standard care. Or placebo, and we will know the meaning of placebo. Or careful follow-up with no intervention, or higher or lower doses of the drug which will be tested. What is a placebo? A placebo is a pill, liquid, or powder that contains no drug and has no treatment value, but it just looks like exactly the real drug. Okay? There are fundamental principles that should be applied on the control groups. So what are these fundamental principles? Groups must be alike in all important aspects. Only the difference between them is the intervention. What is blindness? Blindness means masking the identity of the assigned intervention. In open randomized controlled trials, there is no blindness. In single blind randomized controlled trial, the participant don't know if he was assigned to the intervention or control arm, but the investigator knows. In double blind randomized controlled trial, both the participant and the investigators don't know the identity of the intervention and control arm. Also, there are more advanced types of blindness, like the triple blindness, in which the person who is going to do the statistical analysis of the study also doesn't know. Using a placebo for the control instead of no intervention will facilitate blindness. However, on the other hand, sometimes blinding is impossible. Okay, for example, in surgical procedures. What are the main randomized controlled trial designs? First of all is the parallel design, in which each group is subjected to one intervention, and this is the most common type of design. The second is the sequential or crossover design, in which each participant is given both interventions in successive periods. Each participant acts as his or her own control, as we can see in the algorithm. Factorial design, when interventions are compared separately, in combination, and against a control in different groups. For example, here group A will receive treatment A, group B will receive treatment B, group C will receive treatment A and B, and group G will receive the placebo. What are the risks and benefits of clinical trials for participants? The risks, of course, are unpleasant or serious side effects. You may receive a placebo. No guarantee that the experimental design will be an effective treatment for you. What are the benefits? The benefits is that you may experience health benefit from a new treatment. You will be provided with free lab tests and expert treatment. It contributes also to the development of a new medication, which will benefit the society as a whole. As you can see here are the outcomes or the endpoints of clinical trials. What are the outcomes or the endpoint of clinical trials? Recurrence, survival, symptom relief, cure, complication, biochemical measurements, physical, toxicity or side effects, quality of life or cost effectiveness. In case of community of field trial, your endpoint may be measuring the incidence, measuring the mortality, measuring and assessment of quality of life, okay? Measuring or assessment of the cost effectiveness of a certain intervention or a program. Here are the different types of the outcomes or endpoints of clinical trials. The direct clinical endpoint, in which the outcome that represent direct clinical effect to patient or participants, such as survival, decreased pain, or the absence of disease. Surrogate endpoint, in which a substitute for a clinical endpoint used in trials, where the use of a clinical endpoint may not possible or practical. For example, a drug direct effect benefits would take many years to measure. Here you should use a surrogate endpoint to predict the clinical benefit. For example, the tumor shrinkage in case of drugs for treatment of certain types of cancers. What are the main limitations of clinical trials? The main limitations of clinical trials is that they are expensive, take a long time, only used to certain type of questions. There are multiple ethical issues around randomized clinical trials. For example, not possible to use randomized clinical trials to test the effects of exposures that are expected to be harmful. Okay? We finished our last slide about the experimental research, mainly in the form of randomized clinical trials. Please, if you have any questions, write it in the chat box. Okay. Thank you very much. Okay, thank you very much. I will leave you now. Goodbye.
السلام عليكم. ازيكم يا دكاترة؟ عاملين ايه الأخبار؟ النهاردة هنتكلم عن الكلينيكال ريسيرش من البداية خالص، وهنتكلم بالتفصيل عن كل نقطة في موضوع الكلينيكال ريسيرش، بداية من الديفينيشن بتاعه، ايه الأهداف بتاعته، ايه الأنواع المختلفة اللي فيه، الethics we have to follow in order to produce a strict and clean clinical trial in order to be accepted in many of the journals that are international and peer-reviewed journals also. Okay, so let's start with the objectives of our lecture today. First, we will talk about the clinical research as we stated previously, and we will talk about the definition of the clinical research, the different types of the clinical research. And also there is always a conflict in the mind of several physicians and the clinicians about the difference between clinical research and standard care. We will try also to address this point. Then we'll talk about why do we perform clinical research? What's our aim? Because clinical research is not an easy process. It's very difficult and consists of many different steps. So we have to know what is the aim, what's the aspiration at the end of any clinical research. After this, we will try to explain the different types of clinical research. We have different types of studies, and we will try to explain briefly the details of each design. Okay, then we will try to summarize how to perform a clinical trial, because as you know, in most of our theses and most of our postgraduate studies, we have to conduct a clinical trial in order to obtain the certificate at the end of the postdoctoral study, the postgraduate study. So we will try to explain the steps that we have to follow in order to finish our studies in the future. Okay, I will maximize the screen, don't worry. Okay, we'll try to explain what is the meaning of a clinical research. The clinical research aims to find a new piece of knowledge that's not known previously in the literature. Okay, I will try to mix my explanation between English and Arabic in order to deliver my presentation clearly and completely. So the definition here about the clinical research is the scientific study that involves people. Okay, so individuals will volunteer in order to participate in a clinical trial which aims at the end to provide a new piece of knowledge. And here we have various types of clinical research. For example, if a pharmaceutical company wants to know about the effect of a specific intervention, its aim is to know whether this intervention will be better than the standard interventions that's used currently in our time. So this company will have to perform several scientific studies in order to study the effect of this intervention. Moreover, if we have a new diagnostic tool, for example, and I will try to talk from my scope as a physical therapist. Physical therapists have many tools in order to diagnose different diseases. For example, we could use ultrasonography in order to examine different sprains and strains in different muscles and musculoskeletal conditions. So we could create a questionnaire or even any new tool which will be cheaper and easier. So the clinical research will be our route in order to know whether this questionnaire or whether this tool will be better than the standardized ultrasonography or not. So clinical research aims always to provide a new information to add it to the literature in order to benefit the scientific world and also the whole population in the future. And when we talk about the clinical research designs, we talk about two main types, okay? And here I wrote that clinical research could be divided into two categories, the interventional category and an observational category. Okay, let's talk more about these two types, okay? Don't worry about the too much details that are presented in the PowerPoint because I try to be comprehensive and include all the details in the presentation. Just try to listen to me and all the data will be simplified to you. Observational studies, and I think this is very simple and this is very understandable from the word observational. Observational means that the investigators and the researchers will not use any intervention in the experiment. They will not use any drug during the intervention. They will not be in a continuous contact with the participants. For example, if we want to know the effect of smoking in a group of population, on a group of people, okay, so we will remotely observe these people who are smoking, and also we'll try to get another group of people who are not smoking in order to know at the end whether smoking will affect their body structures, their body physiological process or not. So in this process, we didn't include any intervention. We only try to observe the process of the development of diseases as a result of smoking. So here we are talking about only observational studies. In other words, if you want to talk about interventional studies, so contrary to observational studies, we have to provide an intervention. We have to provide a medication. We have to provide a diagnostic tool. So there will be a group of investigators who will be in a continuous contact with the participants. We will set some standardized rules that the intervention will be provided within. And at the end of the experiment, we will have a result. And this result will be directly due to the cause that we have provided in our experiment, which is the intervention. So, observational studies are not aimed to provide a cause and effect relationship, but the interventional studies are aimed to do this, are aimed to fulfill this purpose, to provide a relationship which is a causal relationship in order to provide the result at the end. For example, as we stated previously, if you want to know the effect of a certain drug on a certain group of people, for example, stroke patients, and we want to know whether a drug will be effective in improving their motor skills. So we will include a group of patients with stroke and provide them with the intervention, and at the end we will analyze the results. At the end we will measure the outcomes in order to know whether the intervention was effective in improving their motor skills or not. Okay, so we have stated what is the meaning of clinical research, and we stated that clinical research aims always to provide a new piece of information in the literature in order to address a gap of knowledge, okay? And we also said that clinical research is divided into two categories. The first category is observational studies, and the second one is interventional studies. And we also know currently what's the difference between observational studies and interventional studies. Also, this is a piece of information that I want you to know. Clinical research could be conducted in only one place, and at this time we will call it, or we will name it, as a single center study. Okay, but if we try to conduct the experiment in more than one place, for example, in Saudi Arabia, if you want to conduct an experiment in Riyadh and Jeddah and other governorates or other cities, we will call this type of experiment as a multi-centered experiment. And by the way, multi-centered studies are more practical and are more better than single-centered studies. I know that single-centered studies are very easy for several researchers because they will not have to travel to other cities, or also they will not have to recruit other investigators in order to perform the clinical work. But multi-centered studies will provide data which in terms of the external validity will be better from the single-centered studies. Okay, here we are going, I'm sorry for missing the title here, but the title of this slide is the main ethics that we have to follow in order to provide a safe clinical trial. And safety here refers to the participants because we are dealing with humans. And even if we are dealing with animals or even any other creatures, we have to deal with them with mercy. So after the World War II, and I will try to tell you a story about this, during World War II, the Nazis tried to conduct cruel experiments on several British and French captives in order to reach to certain results after these experiments. So after the end of the World War II, several organizations around the world tried to gather in Nuremberg in order to state the guidelines that must be used in conducting any clinical research or any clinical trial in order to preserve the human rights while doing any research paper. Okay, so the first principle that we have to know in order to conduct a research paper is justice. And here, what is the meaning of justice? Let's try to read this paragraph. No group should carry more than their fair share of the burdens of research. Those who participated should have access to the benefits of the results, and no group should be unfairly excluded from the research. And here we will try to give you an example. So, as you know from the previous lecture that was before me and was provided by Dr. Wala, that in clinical trials we have to randomize the participants into two groups: the treatment group or the interventional group, and the other group is the controlled group. Okay, so if we are conducting an intervention in order to know whether this intervention will improve for example, the motor skills of stroke patients, so the intervention group will benefit more from the intervention than the control group, especially if you are providing the control group with sham intervention or no intervention at all. So we have also to provide the control group with other methods in order to improve their symptoms and signs, because if we don't do this, at the end of the clinical research trials, they will not be benefited by anything. So we have to stick with justice while doing any clinical trial, because as we stated previously that we are dealing with humans and we have to do this. Okay. As we stated in the objectives, that we will speak about the difference between clinical research and standard care. In clinical research, physicians and clinicians are dealing with volunteers or even patients, and patients may volunteer in a clinical research in order to benefit the societies afterward, because patients will participate in this clinical research and they know that the results of these trials will help clinicians and physicians take better decisions in the future. But in the standard care, we are dealing with patients that came to our clinics in order to be provided with a treatment for their medical conditions. So they are not aiming to benefit society in the future, but the participants of clinical research who provided the investigators with informed consents and know all the risks and know all the benefits of the clinical research, and they provided an informed consent according to this. They are aiming to help the populations. They are aiming to help the patients from the same with the same medical conditions. In the contrary, standard care is not aiming to provide a new piece of information. Standard care is not aiming to address a gap of knowledge in the literature, but clinical research is doing so. Clinical research helps the scientific society to know more about different diseases, to know more about different interventions, to know more about different diagnostic tools that might have better specificity and sensitivity than the gold standard tools. Okay. Also, during a clinical research, we could gather information through interviews or observations. In contrary to standard care, we try always to use some standardized tools and some standardized radiographic findings in order to give the specific diagnosis to the patient. Okay. Also, in clinical research, we try always to compare the intervention group with another group in order to know the results of the clinical research at the end. For example, as we stated previously, if we want to know the effect of a specific drug on patients with stroke, we will choose a group of patients with stroke, okay? And then we will divide these groups using randomization into two groups, the experimental group and the control group. And at the end of the intervention and at the end of the study, we will compare the results between these two groups. And by this, we will know whether the intervention is effective or not compared to the control group. So the comparison and the control group is very effective method in order to know the efficiency and the effect of any intervention. Without a control group, we cannot know whether this intervention is effective. Without the control group, we cannot know whether the effect was due to the intervention or was due to some psychological causes. Okay, because as you know, there is something that's called the placebo effect of drugs, and the placebo effect of drugs is always due to some psychological issues among the patients. Okay. And this control group or this comparison is not included and is not available in the standard care. So this is also an additional difference between clinical research and standard care. Here also a question that we explained previously about why do we perform clinical research. And as we said, clinical research is undertaken to collect data on usual and unusual events, condition and population groups to allow us to observe treatment and the health management practice. And at this point, which is health management practice, I want to give a comment. In the NHS, which is the National Health System of UK, there is something which is called audit study. The benefit of this audit study is to compare the health management practice of different departments in the national health system and try to compare these practices with the international guidelines. So, if you want to apply to a position in UK, in America, or even in some hospitals in Saudi Arabia, I think there will be some questions about your ability to perform an audit or not, because this audit aims to improve the health management practices that are provided to the patients, and they are very important. So this audit study or this audit process is about comparing the practice of physicians, nurses, dentists, pharmacists, physical therapists by the international guidelines. For example, if I am a neurophysiotherapist here in Egypt or even in Saudi Arabia, and I deal with patients with specific techniques and specific treatments, so my manager or the investigators who are responsible of the audit study will come to me and try to compare my protocols in the treatment of patients with the internationally published techniques and try to find whether I stick to the clinical practice guidelines or not. And by the way, it is very important and it is very essential in any health management system. I think all of you clinicians know this piece of knowledge that during the 20th century, and especially after the end of World War II, we were able to perform exceptional clinical research trials, and we discovered new treatments and new discoveries that were out breakthrough during this period of time. So, in 1950s, epidemiological research proved that cigarette smoking caused lung cancer. And as you know, at the beginning of smoking, there were some propaganda about the benefits of smoking and how smoking could help us be more calmer and be more able to concentrate on our work in different fields. So in 1950s, we were able to prove that this is not right, and smoking has several negative impacts on different body organs, for example, lung cancer. Also, afterward, we were able to prove the relationship between folic acid and the spina bifida in babies. And currently, I think most of the pregnant women try to stick to folic acid during their pregnancy. Also, afterwards, we were able to know that we could reduce the progression of AIDS by using a combination of antiviral drugs. All these exceptional discoveries, we know about them by clinical research. the importance of this slide for you is to know the importance of conducting a research trial. So even if you are a student in a postgraduate study, or even if you are a clinician and noticed an unusual habit or an unusual effect of a specific drug, you could use this notice in order to publish a paper. Because this paper, even if you consider it as a small thing, it could be beneficial to a whole of populations in the future. Okay, I think we explained previously, or I think we used the word informed consent while we were explaining some data before. But let's talk about informed consent in detail. What is the importance of informed consent? Okay, in the beginning, we have to state a rule that we couldn't use participants in any clinical research trial, or even here we are talking about any type of clinical research. We are talking about observational studies. We are talking about interventional studies. So we cannot include any participants in a clinical research without using an informed consent. So these participants, by signing this informed consent, will admit that they know the risks of this experimental study. They know the benefits of this observational study, and they consent to all the risks that they might face during this study. And also, they admit that they have freely participated in this study. Okay, so this informed consent is an essential part of any study. So if you are going to start a protocol in order to start your thesis to get the master degree certificate or doctorate degree certificate, you have to provide a protocol for the ethical committee of your university. Okay, and one of the main parts of this protocol is informed consent and what you included in this informed consent. Okay, and as I stated previously, that all the participants have to sign this informed consent in order to admit that they have freely participated in this clinical experiment. But let's talk about why they have invented this regulation, why they have stated previously that informed consents have to included mainly in any clinical research. Because as I told you previously that during World War II, the Nazis was performing cruel experiments on British and French captives without their agreement. So, after the World War II, there were some agreements in Nuremberg, which is called 1947 Nuremberg Code. And after this, there was another meeting in Helsinki in Finland, which stated some guidelines. And one of the most important guidelines that all clinical research investigators have to follow is to include an informed consent in their protocol. Okay. Let's talk about what's the meaning of informed consent and what should be included in the informed consent. So, the informed consent should fully inform the potential participant of all applicable parts of the study, such as its purpose, duration, required procedures, and the key contexts. So, the patients have to get all these details before signing the consent. Okay. Also, if you are going to deal with patients that they are not able to give a decision, and here we are talking about children, about mentally disabled patients, we have to deal directly with their family members or relatives or any person who is responsible of them. Also, if we are going to deal with Arabic participants, so the informed consent should be in Arabic. Okay, we couldn't use an informed consent with another language with the public speaker of the country. So if you are going to deal with English speakers, the informed consent should be in English. If we deal with Portuguese speakers, the informed consent should be in Portuguese. Okay, so why we have to do this? In order to make sure that the participants are able to understand every detail in the informed consent. And by the way, this is very important not only for the participants, but also for us as researchers, because if some patients after the end of the study complained that they were in risk during the study, so we will provide them with the informed consent that they have signed before the beginning of the study. And we will say that they knew previously all the risks and benefits of the study, and they give us a consent to conduct and to participate in this study. Okay, so we have, let's try to summarize the previous section. Okay, I think we explained what's clinical research. And also, we tried to give a summarize about the difference between clinical research and standard care. We provided you with the main ethics that we have to follow during conducting a clinical research, and we said that justice is very important guideline. And also, we provide you by several reasons of why we do perform clinical research. Okay. Moreover, we explained the informed consent and also provided the reasons and the importance of conducting a informed consent and including it in our protocols. Okay, so currently let's talk about the epidemiological studies or clinical research and its types. As we stated previously, we have two types of clinical research. We have observational studies and we have experimental studies. In observational studies, we don't manipulate any interventions. We don't use any new diagnostic tools. Clinical research are not in a direct contact with patients. You don't provide them with anything. So, clinical research investigators will have no effect on the end result of the study. They are just observing the flow process of a specific disease. They are just observing the flow process of a specific diagnostic tool or of a specific phenomenon. And as we stated and as we mentioned previously, that if we want to know about the effect of smoking in a group of population, we don't have the ability to let or to force some participants to smoke. But what we have to do is to observe a group of participants smoking and other group with the same characteristics and with the same traits that they are not smoking, and try to find the comparison of the results between them at the end of a study. By this, we will be able to know the difference between the group who is not smoking and the group who is smoking. But ethically, we are not able to force some participants to smoke because this will be dangerous to their health in the future. Okay. We have two types of observational studies. We have case report and series, and we have also analytic studies. But regarding experimental studies, we have two types, which are randomized controlled trials and quasi-experimental trials. We will speak I will explain in detail the analytic observational studies, but let's explain in brief the case report and series. Case report or a case series is a paper which introduces to the literature an unusual event or an unusual symptom of a specific syndrome or disease, or an unusual effect of a specific drug that is not published previously in the literature. For example, regarding stroke, we will stick to this example till the end of the lecture. Regarding stroke, if I am as a clinician in my clinic and I was visited by a patient with stroke, okay, then I observed a certain symptom in this patient that is not explained or mentioned previously in any textbook or in any published research paper. So because I am a well-known clinician and also because I am a well-known researcher, so I write this notice in a case report in order to introduce this piece of information to the scientific world. Okay, but regarding case series, okay, I will try to explain to you the difference between case report and case series. Both studies have the same aim, okay, but case report deals with 1 or 2 patients maximum, but case series can deal with more than 2 to 6 patients maximum. Okay, so this is the difference between case report and case series. Case report deals with a minimum number of patients, okay, but case series deals with more than 2 or 3 patients. So here we are talking about a type of studies or a type of publication that's not effective in order to know the relationship between something and other. It's just important in order to give the scientific community a look about a new symptom, a new effect, a new unusual event. And after this, the clinical trials could be conducted in order to affirm this effect or refuse and reject this unusual event. Okay. So we are still with the types of epidemiological studies, and we stated that we have 2 sections or 2 categories in epidemiological studies. We have an observational studies and we have experimental studies, and we explained the case report and the case series, which are a part of observational studies. But when we come to talk about analytic studies, we are going to talk about something which is more complicated and more informative than case report and case series. Okay. Firstly, we want to know about the different categorization of study designs. We have a categorization of studies according to the intervention, okay, and we have another categorization according to design, and the last one will be according to time. So we have 3 categorizations. We have 3 divisions. Each one will depend on one factor. The first categorization will depend on whether there is an intervention or not. Okay. And the second one will depend on the design of the study we have conducted or we have planned. And the third one will depend on the time that the study took place or the time that the study was conducted. Okay, and we will explain this in detail after this slide. According to the intervention, we have mentioned previously that we we categorize studies into observational studies and experimental studies. And I think this is clear to you. Observational studies, we don't use any interventions. There is no direct contact between investigators and participants. Whether on the other side, experimental studies or interventional studies, we have a direct contact with the patient. We will manipulate with their interventions. We will use new diagnostic tools with them. So that's why it's called experimental or interventional study. While according to design, we have qualitative study and we have quantitative study. And here we are talking about the type of data that we collected from the patients. I think in previous lectures or maybe in following lectures, you will know more about types of data. And that there are some data that's called qualitative and other data is called quantitative. So if we gathered data which is qualitative and couldn't be analyzed using sophisticated statistical analysis methods, so this study will be called qualitative. But if we gather data which is quantitative and could be analyzed by different statistical methods using different software programs, so at this time, we will call this division as quantitative studies. Okay, so we explained that we have a categorization of studies according to intervention, and we have a second categorization according to a design, and the third categorization that we will talk about it currently will be about time. So we have 3 study designs. The first one is retrospective. The second one is prospective. And the last one is the cross-sectional study. What is the difference between them according to the dimension, which is time? The first one, which is retrospective, we are looking at data that have already been gathered. Okay, so 10 years before or 10 years ago, we have 100 patients with stroke. We will try to gather data about these patients with stroke 10 years ago, because as you know, that the national health system in different countries will have data about patients from different years. So we will deal here in the retrospective study design with data that was collected previously in time. We are not dealing with the future here. We are dealing with the past. But when we talk about the prospective study design, we are dealing with the future. Okay, I will give you an example about this. Let's talk about a study design that used in order to know the effect of smoking on smokers after 2 years from now. Here, we are dealing with the future. We are dealing with a prospective study because the data will be collected in the future. That's called a prospective study. But we wanted to know what is the effect of smoking on smokers who in 2015. Okay, let's try to explain the question more. We want to know the effect of smoking on smokers who started smoking in 2010 in 2020. So our study was conducted in 2020, but we want to know the effect of smoking on smokers who started smoking in 2010. Okay, so retrospective studies always deal with the past, but prospective studies deal with the future always. Okay, the last one, which is the cross-sectional study. The cross-sectional studies don't deal with the future or the past. It deals with the current status of any outcome that we want to know about. Okay, let's try to know the prevalence of the prevalence of depression and anxiety disorders among students in a specific university in Egypt, okay, or in Saudi Arabia. So we will use a questionnaire or even any other diagnostic tool in order to collect data from these participants. So here we are dealing with the future, we are dealing with the present status. We are dealing with a specific point of time in the present. We are not dealing with the future, we are not dealing with past, but we are dealing with the present status. Okay, so this is difference between retrospective studies, prospective studies, and cross-sectional studies. Okay. Previously, we explained that we divide epidemiological studies into two categories, which are observational studies and experimental studies. And also, we divided observational studies into two categories, the case report series and the analytic studies. And also we stated that experimental studies could be divided into randomized controlled trial or quasi-experimental trial. Let's talk more about these different types. The first study design is a cohort study. And if you noticed here that cross study is forward in time. So cohort study is one of the examples of the prospective study designs, because we are not dealing with the past, we are dealing with the future. So firstly, how could we conduct a cohort study? And please take into consideration that cohort study is one of the examples of the observational studies. So we will speak about our standard example. If we want to know the effect of smoking on lung cancers in smokers, so we will choose 1,000 smokers and choose other 1,000 humans with nearly the same traits, with nearly the same features, with nearly the same medical background, okay? And then after the passage of 2 or 3 years, we will try to compare the results that we have taken from smokers with non-smokers. So by this, we were able to know the effect of a specific risk factor in people without using any intervention, because here smoking was not forced by any investigators. We didn't use smoking as an intervention in our experiment. Okay, so this is a type of observational studies that we have two groups of people. Okay, a group of people smoking and the other group is not smoking, and we observe them during several months, several weeks, several days, several years, and after the end of this period, we will try to compare the results between them. So cohort study is a type of the prospective studies, and also it is an observational studies. The investigators are not dealing or not provide participants with any intervention. They are just dealing with the flow process of a specific risk factor which here in our example is smoking. Okay. So what are the advantages of cohort studies? It could provide us causality. Cohort study is the strongest observational study that could provide a causal relationship between a risk factor or between an intervention and the result, because we provided two groups. One group is smoking, and at the end we compared the results between both groups. So we could say that the risk factor was the cause of this result. But there is a huge difference between cohort study and randomized controlled trials. And I think all of you know the difference between both study designs, which is an important step, which is randomization. We didn't include randomization in cohort study, but in randomized controlled trials, in order to make sure that the participants of the both groups are same in any characteristics and there are no confounding variables that could affect the results, we use randomization. Okay, so yes, cohort study could provide us with a causal relationship, but it's not as effective as a randomized controlled trial. Okay. And here is a diagram that could summarize to you the cohort study. We have here a group of people, the population, okay? And we want to know the effect of a certain factor on the presence of a disease. We want to know the effect of a certain risk factor on the presence of the disease. The risk factor that we have stated in our example is smoking. And please remember this example because we will use it in explaining the case control studies. So here we want to know the effect of smoking on the development of a risk factor, which is lung cancer. So we bring a group of healthy subjects, okay, and categorize them into two groups according to their smoking status. So if they are smoking, we will put them in the exposed group. And the meaning of the exposed group, that this group is exposed to the risk factor, which is smoking. And the other group will be the unexposed group. The unexposed group means that this group is unexposed to the risk factor. So in the cohort study, we start with a healthy group of participants. Some of them are exposed to a risk factor and the other group is not exposed to the risk factor. And after time, we want to know the comparison between the two groups according to the development of a specific disease like lung cancer in our example here. Okay, please remember this diagram because this will be very important in explaining the second study design, which is the case control study design. Okay. The case control study is different from the cohort study design because we deal here with the time in the past. We are not starting with a group of patients that are healthy. We start with a group of patients that have the disease, and let's use this diagram as an example. Okay. Look, we are here in time. Okay, we are here in time. In case control studies, we want to know whether a risk factor was a cause in the development of the disease or not. please focus on my words. We want to know whether a risk factor was the cause of the disease or not. Was the cause of a disease or not. But here, in the cohort study, we want to know whether a risk factor will be a reason for the development of a disease or not. So, logically, in the case control study, we will start with two groups of participants. Both groups have the disease. In the case of lung cancer patients, we want to know whether smoking was a risk factor in developing lung cancer or not. So, we choose a group of participants, okay, with lung cancer, and then try to compare between them whether they were smoking or not. Okay, and we will bring a group of participants smoking and have lung cancer, and other group have lung cancer and not smoking, and try to compare the results between them. So in case control study, we are dealing with the past. Okay, we want to know whether a risk factor was an example in the development of lung cancer or not. Let's give me an example for you. If you want to know whether alcohol is a risk factor for development liver cirrhosis or not. So if you want to conduct a cohort study, we will bring 1,000 healthy subjects, okay, and we will divide them into two groups. The first group drinks alcohol and the second one is not drinking alcohol, and after 2 or 3 years we will compare both groups regarding the development of lung cirrhosis, liver cirrhosis. Okay, but when it comes to the case control study, we want to know whether drinking alcohol was a risk factor for the development of liver cirrhosis in patients with already liver cirrhosis. So we will bring 1,000 patients with liver cirrhosis. 500 patients were not drinking alcohol, and 500 patients were drinking alcohol, and try to compare the incidence of the disease between them. Okay, so this is the difference between the case control study and the cohort study. We know that case control study and cohort studies are both designs of the observational studies. The last study design here is a cross-sectional study or the prevalence studies. And I think we mentioned this study design while we were talking about the type of study designs according to time. We said that cross-sectional studies aim to provide a piece of information in the present. We are not dealing with the past, we are not dealing with the future, but we want to know the prevalence of a certain medical condition among the population in the current period of time. So if you want to know the prevalence of smoking among university students, we will use cross-sectional study. If you want to know the prevalence of depression and anxiety disorders among stroke patients in the current status, we will use cross-sectional studies. Okay, so by the way, cross-sectional studies are very simple to be conducted, and also it could provide important data, because important data. However, they are not as important as cohort or case report studies, and for sure the randomized controlled trials. I hope that this part was simple to you, because currently I will give you just 2 minutes before beginning the second hour, in which we will talk about the randomized controlled trials in detail. Hello again, everybody. Okay. We have finished the 2-minute breaks that I provided to you, and currently we will explain in detail the randomized controlled trial and try to explain the important and essential steps that every student or every researcher have to follow in order to complete the study. Okay. Firstly, we have to revise what we have said in the previous lecture, that randomized controlled trials are one of the examples of the interventional studies. And we stated previously that interventional studies is a part of the epidemiological studies. And also we have said that the other category is called observational studies, in which we don't have to provide any specific intervention, and also you don't have to be in a direct contact with the participants. But here in randomized controlled trials, the process is completely different compared to observational studies. And here is a question: what is the importance of randomized controlled trials? Because if you want to know the importance of randomized controlled trials, we have to know the disadvantages of observational studies. And I think we have stated this in the previous lecture, that using observational studies, we will not be able to provide a causal relationship between different variables. And as we stated previously, that if you want to know the effect of a specific intervention, or we want to know the effect of a specific diagnostic tool, we don't have to use observational studies. because observational studies will not provide us with a causal relationship. But using randomized controlled trials, we will be able to infer this relationship. We could make a statement that say that this intervention was a cause for the improvement of a specific symptoms and signs in patients. Okay, we could say that this diagnostic tool was very sensitive and was very specific in order to diagnose a specific medical condition. We could say that a specific risk factor was a cause for the development of a certain disease. Because, as we stated in cohort and case report studies, that yes, we could use them in order to the identification of certain risk factors for the development of certain diseases, but we couldn't give a 100% assurance that this risk factor was the reason for the development of the disease. But here in randomized controlled trials, we could do this. So, what is the difference between randomized controlled trials and observational studies? Let's explain this diagram. We have here the population, okay? We have here the population, and we, at the beginning of the study, or at the beginning of the randomized controlled trial, we have to explain in detail our selection criteria. So what is the meaning of selection criteria? Selection criteria means the features that must be in patients in order to be eligible to participate in the study. So if I deal with a study in order to investigate the effect of a specific intervention in patients with stroke, so one of the main selection criteria of my study is patients with stroke. So I don't have to deal with patients with spinal cord injury. I don't have to deal with patients with Parkinsonism. I don't have to deal with patients with any other medical condition, because my selection criteria states that I have to deal with patients with stroke. This will be very important for the readers, because when a clinician wants to know the effect of a specific intervention on patients according to the selection criteria, this clinician will know whether this study will be relevant to his practice or not, his or her practice. So, firstly, we have the population, and according to the selection criteria, we will select potential participants. So if we have a hospital, this hospital have about 100 patients. According to selection criteria, I think, or I guess, that there is about 20 potential participants. But by the way, these participants haven't been included in my study. Okay, firstly, before including these participants in my study, I have to invite them firstly. As we stated previously in the previous lectures, that participants have the right to choose whether to participate in the study or not. They have to reject if they want to reject, and they have to participate without any restrictions. Okay, so investigators mustn't threaten participants in order to force them to participate in the study. So, according to the selection criteria, we will select a group of potential participants, and all these potential participants will be invited to participate in the study. Okay, a group of these participants will agree to participate in the study and others will not. So we will deal only with the participants that have agreed to participate in our study. So the first step in my randomized controlled trial, that I have to set the selection criteria. I have to know the potential participants, and then contact all these potential participants in order to invite them to participate in my study. if they agree to participate, and before their agreement, they have to know all the risks, all the benefits, all the details about the study, then they will agree. If they agree to participate in my study, so they will be considered as volunteers or participants in my study. So if they don't agree, there is nothing to do with them, okay, and they will be non-participants. Okay. After the agreement of the participants to participate into the study, they will pass by a step which is very essential and very important in conducting randomized controlled trials, which is the randomization process. Let's talk about the randomization process and try to explain its reason. Okay. The reason for conducting the randomization process is to divide the participants into two groups that are equal in each detail, that are equal in each feature and in each characteristic. For example, randomization will provide me with two groups that statistically are not different regarding anything. So when it comes to know the result of a specific intervention at the end of the study, okay, when it comes to know the result of a specific intervention at the end of the study, I will be sure that this result was due to the intervention. Why I am sure that the result was due to the intervention? Because I know that the both groups were equal in each thing. The both groups don't take any drugs or didn't do anything extra during the study. So for sure, the result was due to the intervention. The result was due to the treatment, because there are no confounding variables that could interfere with my results. This is the importance of the randomization process. And there are many methods that could be used in order to perform the randomization process, but here we are talking about the logic, the logic behind it itself. Okay. And after this, we will provide the intervention or provide whatever the methodology that we want to apply, and discover at the end whether the controls were better than the treatment group or whether the treatment group were better than the control group. Let's try to read this slide in detail. RCT has become the accepted standard for evaluating therapeutic efficacy. It is the standard way in order to know whether an intervention is effective or not. It is the standard way in order to know whether a diagnostic tool is effective or not. It is the standardized tool in order to know the effect of a risk factor for the development of a specific disease. So, in order to infer a causal relationship between different variables, we have to use randomized controlled clinical trials. That's why it's a gold standard for concluding a causal relationship between two variables. Randomized trials are performed in a prospective fashion to allow as much control of variables as possible. Okay, this is a very important statement. Randomized controlled trials are considered one of the designs of the prospective study designs. And here we are explaining why we have to perform these randomized trials in the future. We have to deal with the future. We don't have to deal with the past, because if we dealt with the past, we will not be able to manipulate all the variables. We will not be able to control all the variables that could interfere with the results. So if we dealt with the past, or if we deal with the past, we will not be able to make sure that the relationship that was resulted from the study design was causal. because maybe there were some variables that interfere the results and that we don't know. Okay. As we said, the outstanding feature of randomized controlled trial is the use of randomization. Why? To help prevent bias in the assignment of subjects to specific intervention groups. And this is very important because in some studies, okay, for example, I'm a physical therapist who deal with patients with several neurological disorders. But because I am a physical therapist in a specific hospital, I gathered 100 patients and I know that 50 patients maybe are better than the other 50 patients. So I included the better 50 patients in the intervention group in order to conclude better results. And the worst 50 patients were included in the control group to make sure that the results of the intervention group will be better than the control group. Randomization will be able to prevent this bias. And by the way, this bias is called a selection bias. What does the meaning of selection bias mean? That the results were due to a problem, due to an error in the selection of the participants of the both groups. So the absence of the randomization will lead to a selection bias. And what is the meaning of selection bias? Means that the results may be not due to the intervention, but maybe because there was an error in the assignment of participants to the groups. That's why we will not be able at this point to make sure that the effect, the result was due to the intervention directly. Okay. If randomization is carried out properly, differences in outcomes that are observed among treatment groups tend to result from treatment effects and not from inherent differences among the groups. And here, what we was talking about, that randomization will clear any differences between both groups, will clear any selection biases, will clear any errors. There is no chance that the result of the intervention will be due to the difference between both groups. Okay. However, RCTs are often difficult to conduct. Many clinicians and patients are reluctant to accept randomization, especially one of the proposed interventions is particularly desirable or undesirable. Okay, let's give an example about it. So if I am a physiotherapist and I prefer electrotherapeutic techniques more than manual therapeutic techniques. So, and I think you remember the 100 patients with strokes that I talked about previously, that we have 50 patients with better inherent characteristics than the other 50 patients. So I used with the 50 better patients electrotherapeutic tools, and I used manual therapeutic tools with the other group. Here, I used my thoughts and included my beliefs in the study. So here we have a selection bias. That's why randomization is very important. And by the way, if you try to investigate any of the questionnaires that investigate the quality of the randomized controlled trials, you will find always an essential section about randomization and how we could assess the randomized controlled trial to know if they were if they stick to the randomization techniques properly or not. And also, by the way, randomization is an ethical consideration. Okay. And I think the following words are repetitive and we don't have to waste our time with them. Okay. The other type of experimental designs are quasi-experimental design. The difference between quasi-experimental designs and randomized controlled trial is in the randomization. In quasi-experimental designs, we are not able to randomize patients. So if you read a study design or a study, and during reading methods, you don't read anything about randomization, you have to know that this is a quasi-experimental design. A quasi-experimental design means that we are talking about an intervention study. So in this study, investigators are dealing directly with the participants and they are manipulating with their interventions, they are manipulating with their risk factors, they are manipulating with their diagnostic tools. So this is considered an interventional study, but unfortunately, we are not able to randomize the patients due to some conditions, due to some regulations, due to some restrictions. We were not able to provide randomization to the patients. So this is a quasi-experimental design. Also, quasi-experimental design could provide us with a causal relationship, but not as perfect as randomized controlled trial, because randomized controlled trials have the advantage of randomization. Let's talk more in detail about randomized controlled trials and the steps that we have followed in order to perform a randomized controlled trials. The most important features of randomized controlled trials is randomization, and I think we explained randomization in detail previously, and also they are controlled. What is the meaning of controlled? Means that we control the confounding variables that could interfere with the results, that could interfere with the causal relationship between different variables in the study. So, because the randomized controlled trials are and our control are all the standard. We control the confounding of the end of the study. That the results were due to the intervention and they were not due to any other confounding variable. Okay, that's why we stated previously that randomized controlled trials couldn't be conducted in the past. They have always to be conducted in the future in order to make sure that all variables are controlled and under control. It's accomplished by randomly allocating subjects to two or more groups, treating them differently, and then comparing them with respect to a measured response. And I think we said this previously, that we randomize patients into two or more groups. Every group will receive a specific treatment, and we will have a control group. And then we will compare the results of specific outcomes among all groups. For example, if you want to know the effect of specific electrotherapeutic tool on pain in patients with stroke. Okay, so we will randomize our patients into three groups. The first group will use, and the last one will use sham electrotherapeutic tool. Okay, then we will use then we use a visual analog scale in order to rate the pain in all patients and compare among the three groups. Okay. Steps in conducting an analysis. Firstly, we have to write a protocol. We have to design a protocol for our study. Okay. The second thing, we have to know the population that we will use in our study. After this, we will use randomization. Then we will manipulate with the intervention or the diagnostic tool. Then we will follow up the patients and assess the outcomes. Let's talk about each step in detail. Okay. I know that the first step for any student and researcher, and I think also that you know this step, that we have to write a protocol. So if we are applying for conducting a clinical research trial, okay, we have to provide a protocol to a specific organization in order to get an agreement about the safety of these interventions on the participants. Okay, for example, if in my faculty I want to know the effect of electrotherapeutic tools in patients with stroke Okay, so firstly, I will design a protocol that specify the population that I will use in order to conduct my study, because this will be very important for the investigators to agree or not agree to my protocol. Okay. Secondly, I will try to specify the place that I will get my patients from. And this is very important to be stated not only in the protocol, but also in the study design, because this will affect the external validity of the study. Okay. Secondly, I have to state all the steps that be conducted in the study design, the way of randomization, okay, the method that I use in order to calculate my sample size, okay, the type of intervention, the tools, and even the brand name of the machines that I use should be included in the protocol. Moreover, I have to mention the statistical analysis tools, what the statistical analysis tests that I will use in order to what are the statistical analysis tools I will use in order to provide the result at the end. Okay, whether I will use the chi-square test, the t-independent test, and etc. After this, as we said before, that I have to include the informed consent in the protocol in order to let the investigators know the criteria that will be included in the informed consent in order to inform the participants with all the risks and benefits of the study. So the protocol is very important at the beginning of any study. And we stated here that we have to apply the protocols to the ethical committee of the university that we are conducting the study within it in order to get an agreement. But currently, we have some international organizations that we could publish our protocol in them, like clinicaltrial.gov. Clinicaltrial.gov is related to NHI, in NIH, and it is a website that's specified for publishing the protocols for different randomized controlled trials in different countries. And if you want to start a clinical trial, you have to publish a protocol on this website. Okay. After finishing your protocol, okay, you have to know the population or target population that you will deal with. For example, currently I live in Cairo in Egypt. So I have to choose the hospitals and the university hospitals that I will choose the patients from them, because if I'm going to conduct a single standard study, I will not be able to travel to several cities or several countries in order to limit myself to the hospitals of my city and my governorate only. Also, if I want to deal with patients with specific age. I have to mention this in the protocol and also in my study. So, for example, if I want to deal with patients with stroke whose age is more than 40 years old only, I must mention this in the protocol and also in my study. Because, as I told you previously, that this will affect the external validity of the study. Okay. Even if I want to deal with a specific race, I want to deal with only African people or even Asian people, I have to mention this in detail in the protocol and also in the study design. So, after writing the protocol and after specifying my target population and the place that I will choose my participant from it, I have to come to randomization. Okay. And I think we explained previously the importance of randomization, and that randomization is very important to eliminate bias and to allow for comparability between both groups. Randomization is the heart of a controlled trial. It will give the greatest confidence that the groups are comparable, that like can be compared with like. Okay. Randomization is done only after the participant has entered the study. That's after having been qualified for the trial and has given his informed consent to participate in the study. Randomization is best done by using a table of random numbers. There are several methods and several ways in order to conduct randomization, but we will not talk about this in detail here in our lecture. But for your information, it's best done by a table of random number. There is simple randomization, that is stratified randomization. If you want to do randomization, it's better to use a table of random numbers. Okay. Let's get to the clinical part of the study, which is the manipulation of the intervention. We have agreed that after the selection of participants, we will randomize participants into two groups, the intervention group and the control group. And in the methods section of your study design, you have to mention in detail the description of your intervention and how you used it in details. You have to talk about the dose, the timing of your intervention. All these details have to be included in your message section. So, having formed the study and control groups, the next step is to intervene or manipulate the study group by the deliberate application or withdrawal or reduction of the suspected causal factor. So, if you want to know the effect of a specific drug on the intervention, we will apply this intervention. If we want to know the effect of a dietary component on a specific disease, we could reduce this dietary component in order to know the effect of this on a specific disease. So, all of these steps, all of these manipulations could be named under the manipulation of the study. We are manipulating the study participants either by the application of a specific drug, the application of a specific vaccine, or even the reduction of a suspected causal factor. And by the way, all of these steps should be detailed in the protocol and also in the study. So, what is the importance of manipulation? We have agreed that we have both two groups or three groups that are comparable in everything, that they have the same characteristics, that they have the same traits, that they have the same features. Okay, so manipulation will create an independent variable. So if we have two groups that are same, using a drug in one group will create an independent variable. So any effect that will be at the end of the study in this group will be due to this independent variable. Okay, so I think this is a consequences, and this is a sequence that have to be followed in steps. First, we have to choose our participants. Second, we have to randomize participants in 2 or more groups in order to provide 2 comparable groups or more comparable groups. And at the end, we have to manipulate the study participants in order to create an independent variable, because at the end, we will be able to provide a causal relationship between the variables. Okay. Okay, what are the variables that could be used at the end of the study? Maybe the incidence of a disease, the survival time, the recovery period. So we could use a study under the name of the effect of a drug on the incidence of lung cancer. Okay, the effect of a drug on the incidence of breast cancer. So the drug here is the independent variable. And why I am sure the drug is an independent variable and there are no confounding variable that may intervene the relationship between the dependent variable and the independent variable is randomization. Okay. After randomizing our participants and manipulating the study participants in order to provide an independent intervention, we have to follow the patients up. Maybe we just take the outcome immediately after the end of the treatment, or maybe we could follow the patients after several years from the end of the treatment in order to determine the incidence of a specific disease, or even we are trying to measure the mortality after applying different interventions, so we have to follow these patients till the end of their life. So follow-up is a very complicated process, but it is very essential in order to know the effect of specific interventions. It's very important to know whether the intervention was effective or not in the long term, because some drugs are not dealing with the short-term effects. They are dealing only with the long-term effects. So we have to follow these drugs for a long period of time. And if you read more about the studies of the pharmaceutical companies, you could find that there are some research studies that started 20 years ago until now they haven't been finished. Okay, so follow-up is a very important step in the randomized controlled trial, and it's very important to try to minimize the number of dropouts of both groups in the study in the study implementation, because you will not be able to control all the participants. So maybe at the beginning of the study you start with 1,000 participants, but at a specific time in the study you will not be able to gather data from all the 1,000 participants because you are not able to control them. So always try to control your participants, try to minimize the dropouts from the groups, because this will be very important at the time of the analysis of the results. However, there is a way in order to address the dropouts of each group that's called an intention to treat analysis. And I think this will be explained in the statistical analysis lectures, but always make sure that you are able to control your participants and you are following always them up. After manipulating the study and following them up, there is a time for assessing the results of the independent variable. Because we started the study in order to assess the results. we started the study in order to assess the results. The main aim of our work is to provide the scientific community with a new piece of information. So this is one of the most important steps in conducting any study. And here we are not talking only about randomized controlled trials. We are talking about all types of study. We are talking about all types of clinical study. We have to use the proper way of assessment in order to provide trustworthy results. So maybe we could get positive results and maybe we could get negative results. What is the meaning of positive results and what is the meaning of negative results? For example, we are trying to know the effect of a specific drug, a specific new drug, on the incidence of lung cancer in patients compared to a standard drug, which is already found in the market. Okay, so when we conducted the study and finished it already, we find that the new drug is better than the control group and the standard drug. So this result is positive because the main core of the question, the main item of the question, the main objective of the question, which is the new drug, was better than the old standardized drug. While if we find out at the end that the new drug was not better than the old drug, or even compared to the control group, here we could call the result as negative. And here the researchers and investigators will be suspicious about the applicability of the publication of their study. Because, as you know, there is an important or a famous statement in the clinical research that publish it or perish it. That means that if you are not able to publish your results, all the efforts that you have conducted in this clinical study will be perished. Okay, so there are some journals and there are some reviewers that don't agree to publish studies with negative results. So when investigators and when researchers conclude that their results are negative at the end of the study, they may be somehow disappointed, somehow sad, because they will be suspicious about the applicability of the publication of their results. Okay. Okay. So the first step of conducting a research study or a clinical research is to write the protocol. It's very important to write a protocol that is comprehensive and includes all the details that will be conducted in the randomized controlled trial. Then you have to apply this protocol to the ethical committee of your university, or even try to publish it. Okay, or even try to publish it in one of the websites that are, or even try to publish it in one of the websites that are specified to publish protocols, like clinicaltrial.gov. Okay, after getting the acceptance for your protocol, you have to choose the place or the setting of your target population. You have to know where you will be able to choose your participant, from where you will be able to get your patients in order to be included in your study. After this, you have to perform the randomization process, and I think we explained in detail the importance of the randomization process. Following this, we have to manipulate the study groups in order to know whether we are going to apply a specific factor, or withdraw a specific factor, or even reduce a causal factor in order to assess a specific outcome. After the manipulation, we have to follow the patients up in order to follow them and prevent the dropouts from the groups, because this may affect the validity of our study. At the end, you have to assess your outcomes, and you may get positive results, you may get negative results. Don't be disappointed if you are dealing with a good journal. If you are dealing with a trustworthy journal, they will deal with the negative results equally as positive results. Okay, let's talk about the risk of bias that may be produced, from the study. We have different types of biases, but here I try to summarize the concept of bias and how we could detect it in our studies. Firstly, what's the meaning of bias? Bias means an error in the conducting of our study that resulted in some results that are away from the truth. For example, we have two groups. Hello? Could you hear me? Hello? Okay, so you could hear me clearly. Okay. Let's continue. Okay, so we here have several types of biases. Okay. And we were talking about a specific example. Okay, let's talk about a study in order to know the difference between electrotherapeutic tools and manual therapeutic tools in dealing with stroke patients. I am a physical therapist who favors to use electrotherapeutic tools because they are much easier. That's why I try to manipulate with the randomization process and include the patients with better outcomes in the intervention group with electrotherapeutic tools, and include the other patients that I know that their medical conditions are not as well as the previous group in the group with the manual therapeutic tool. By this inclusion and by this step, at the end, the group that used electrotherapeutic tool will be better than the group who used the manual therapeutic tools. Was this because the independent variable that was used at the beginning of the study, or because the presence of a confounding variable that intervened the results? I think that the answer is clear. This was because the presence of a confounding variable. The presence of an error in the conducting of the randomized controlled trial. The error here that both groups were not comparable at the beginning of the study. There were some variations between both groups that resulted in a result which is completely away from the truth. That is what bias means. It is an bias may arise from errors of assessment of the outcome due to the human element. Okay, this is a type of the bias, but let's talk about bias again. Bias is a systematic error in the study design that could deviate the results from the truth, that could deviate the results from the truth, and will waste the main aim of the randomized controlled trial, which is concluding a causal relationship between different variables. Okay. And by the way, we have different types of biases. Let's talk about a specific type of bias, which is very important here. We will talk about a bias which could arise from participants, which could arise from those who are applying the intervention, and finally, a specific bias that could arise from the observers, the assessors, who are responsible to assess the outcome. So here we have three types of biases. Okay, a bias that could arise from participants, the ones that could arise from those who are applying the intervention, and the last one that could arise from the assessors. Okay, let's give an example. If if I am a physical therapist who is participating in a study design, and I know the patients who are in the control group, and I know the patients who are in the intervention group. So maybe subconsciously, and here I'm not talking about intentional acts, I'm talking about subconsciously. I will be more concentrating with patients in the independent group, and I will be somehow careless with patients in the control group. So this will lead to a bias, because the difference in the outcomes at the end will not be only due to the intervention, will be due to the knowledge of the investigators or of those who are applying the intervention by the randomization process. Okay, the investigators here, or the researchers here, know which participants in the control group and which participants in the intervention group. So they will give much care for sure to the participants in the intervention group, and will be somehow careless to the participants in the control group. Okay, so this may lead to bias. Also, the bias could result from the participants, because if the participants know that they are included in the control group, they will not be caring a lot with the intervention. They will not be caring a lot with the study, because they know that they are used only to be compared to the interventional group. And on the other side, if the interventional group participants know that they are in the interventional group, that may lead in the end of the study to positive results, they will be more enthusiastic. They will be more encouraged to participate and to stick to the drug and to stick to the treatment. So here, the knowledge of the participants and the investigator, with the allocation of the participants between randomization, between intervention group and the control group, could lead to a bias, which could be avoided by a simple trick. I will talk about it after 5 minutes. And finally, we have something that's called observer bias. Let's give you an example. An observer or the assessor know which patients in the intervention group and which patients in the control group. And here in this study, we are using a subjective assessment tool. We are using a questionnaire, or we are using something that's not objective, that's not a lab analysis test, that's not a radiological finding. So maybe the observer subconsciously, not intentionally, may try to give the participants in the intervention group better results than the participants in the control group. So the difference at the end of the study was not due to the difference between the two groups regarding the intervention, but this was due to the way the participants act, the way the investigator acts, or finally, the way the observers act in order to assess the results at the end of the study. So, what is the solution in order to eliminate all these biases? I think I could give you the answer in one word, which is called blinding. We have to blind the participants, not let them know whether they are in the interventional group or in the control group. And by the way, this would not contradict the ethics of conducting the clinical research. Okay. We have to blind the investigators and not let them know whether they are dealing with the interventional group or the control group. And when it comes to the assessor, we have to force him to assess the subjects without knowing whether patients were in the intervention group and whether patients were in the control group. And currently, we could eliminate all these types of biases, and at the end of the study, we could say that the difference between both groups was due to the independent variable that was manipulated in the study, and not due to the confounding variables. If we dealt with a study that we were able only to blind the participants, so here we name this study as a single blind trial. Okay, so if we read a study, and in the methodology section, they stated that they only blinded the participants, so we could name this study or this trial as a single blind trial. But if the study managed to blind both the participants and those applying the intervention, we will name this study as double-blind trial. And finally, if the study was able to blind all the human factor, to blind all the participants, all the investigators, all the assessors, so we will name the study as a triple-blind trial. Finally, here we talk about the significance of the randomized controlled trial, but I think we were able to explain this significance in detail during our explanation. So if you have any question, please let me know. Please, if you have any question, let me know in the chat. Write your question in the chat and I will answer it. And please give me an opinion about the clearance of the explanation. Was it clear to you? Was it enough to you and comprehensive or not? Okay, doctors, I thank you for your time. Okay, and I hope I was able to convey all the information in a clear way, and I hope. Okay, the quality assessment tool for RCT is not included in this lecture. I think there will be some lectures about the critical appraisal tool, and I think this item will be explained clear in this lecture. So don't hurry, you will provide this. Okay, thank you all for your time, and I hope I could meet you again in other lectures. Thank you.